Recording in progress. Hello.
Good morning, everyone. We welcome you on the second. We welcome you on the.
Good morning, everybody. The first speaker for today is Dr. Neha Sood. Dr. Neha Sood is a good friend of mine, and she's presently working as a principal consultant at BLK Kapoor Max Super Speciality Hospital, and she is a very passionate otolaryngologist, and she's almost experience of more than 19 years in her field. She has received various renowned international fellowships, including a fellowship in cochlear implantation from University of Freiburg, Germany, a fellowship in endoscopic skull-base surgery from University of Pittsburgh Medical Center, Pennsylvania, USA, and she's done a course on foundation course on cochlear implantation from Sydney, Australia. Other than that, she has received the President of India office, the certificate of appreciation from the President of India office. She is, I think, very excited to conduct these kind of workshops, and it was a special request for us to come here. Dr. Neha, I welcome you, and please start the presentation.
Thank you. I would first like to thank my friends here who've taken out time on a Sunday morning, and I know you have a conference, but you still came. So thank you very much. Share screen. नहीं लेकिन आ नहीं रहा ना. कर दिया मैंने. अच्छा, now I'll do. Okay, welcome everybody. I will be talking about CO2 lasers in benign laryngeal lesions. As we all know, the lasers are a very important tool which we have with us, and we can use it to our convenience to do laryngeal surgeries, giving the patient the best possible result without minimal trauma to the surrounding normal structures. So that's our team at BLK, Dr. Ramalingam and myself. I always show this picture because this is something which I think I have learned from Dr. Ramalingam. Um, so lasers is something which everybody is fascinated about. I mean, even from a tympanoplasty to every surgery, I think every patient comes and tells you, "Will you use laser for this surgery?" So yeah, I think it's important to know where and when to use it and how to use it before a surgeon starts using it. So a little bit of the history, because I think everybody has talked about laser biophysics and lasers in detail yesterday. Dr. Rakesh Datta did that. So the first operating laser was started in 1960s. And I think the real invention, the real breakthrough happened when the micro manipulator was developed. And we could deliver the CO2 laser through the microscope. So there are different types of lasers, CO2, ND-YAG, KTP, diode, and holmium YAG. The most commonly used laser is CO2 laser. Even the diode laser is used by many surgeons, like we saw yesterday. Dr. Manjunath showed us the use of diode laser. In our center, we have the CO2 laser. So I'll be talking more about the CO2 laser and showing you a few cases. My whole presentation is a series of short videos. So CO2 laser has a wavelength of 10,600 nanometers, and because it's outside the visible spectrum, we need a coaxial helium neon laser beam to show where the beam will fire. It is strongly absorbed by water. There is minimal scattering, and the area of thermal necrosis around it is very minimal. So what are the advantages? Why should you use a laser over a cold steel? So it is very convenient and it's exact. I mean, it's very precise wherever you want the incision or ablation to be done. That's where it will hit. There is an unobstructed vision of the operating field, less instrumentation, minimal tissue manipulation. There is a longer working distance. There is decreased post-operative bleeding. There is increased sterility. Like I said, minimal surrounding soft tissue damage and better hemostasis. So again, I mean, it is very important to get trained. I still remember when I started using the laser, it was so difficult to fire that shot at the point where you want it to be, where you want the laser beam to hit. It takes a lot of practice, a lot of patience to understand how to use a laser, and I think that is the most important thing when you're using the laser. So all kind of lesions can be tackled: papillomas, hemangiomas, anterior webs, cysts, polyps, nodules, granulomas, laryngoceles, cancers, and stenosis. So this is our laser machine which we are using, and the right side of the picture shows the most common setting which we use for benign lesions. We use it at a power of 5 watts, and we can change the length and the shape of the beam. So usually in benign lesions, like Dr. Sachin Gandhi yesterday explained, it should never be a curved incision. It should always be a linear incision. So we generally use a linear beam, and depending on what size you want, and we use it at a intermittent pulse. We never use it at a continuous mode in benign lesions usually. So these are a series of videos, and I think every video here is unique because we are using a different technique. In this video, like you just saw, we were injecting some saline to make a plane of dissection. So we inject a little bit of saline, fire the laser lateral to the lesion, understand where our plane is, and then dissect the lesion causing minimum trauma to the underlying structures. So I'll just keep playing and I'll keep talking. So there again, there is a lesion on the left cord, you can see, and there is a small contact lesion on the other side. In this video, you can see that we are firing the laser, and you can use different techniques. You can use a forceps to pull the lesion and then dissect it off. You can use a dissector. You can use saline to make a plane. Even while you're dissecting, I think you can pull the lesion. It's very important to pull the lesion, but not too much. Very little medially, so that you can get access. You can see the fibers and then dissect them. So that is what is important. In the last slide, you will see that we will make an incision, because the cyst is on the superior surface of the cord. We'll make an incision lateral to the cyst. And then, because it's on the superior surface, you don't want to damage the underlying structures. So we will use a dissector to lift it off, and then use a laser to fire and remove the entire lesion. So again, a few lesions. So sometimes what we do is we use a suction to pull the lesion, as you can see in some of these videos here. Now it's very important, when you reach the last leg of your dissection or firing the laser, when the specimen is about to come out, you have to leave the suction, otherwise the specimen goes into the suction. That's a mistake I did in my initial days. I didn't realize, you get so over enthusiastic because the specimen is coming out, you forget to leave the suction. The advantage with laser, as you can see in all these videos, is if you have ragged edges, you can always use the beam at a defocused mode and vulgarize the ragged edges. So post-surgery, in most of these videos, you'll see the post-surgery video also, and that is day 1 post-surgery. So you get a very clean area, and you sometimes you can't even make out where the lesion was preoperatively. All these are day 1 images, post-op day 1. The important part is to leave as much of the normal mucosa as possible, so that the healing is good and the vibratory pattern of the vocal cords is maintained, and the patient can have a good quality of voice. Okay, these are pedunculated cysts. So I've specifically kept a few. Now here the issue is, the cyst is so big. So how do you find access? So you can use a suction, push the lesion into the subglottis, and then fire the laser beam lateral to the big cyst, the huge cyst. And it's usually easier if you start dissecting from posterior to anterior, because posterior there is more space, and you will be able to see where you're firing, and the plane is easily accessible. So this is a case of laryngeal papillomatosis, and here we are using the laser beam on a continuous mode. You can see we'll remove all the papillomas, and after we remove these papillomas, there were still papillomas behind the tube. So we took out the laryngoscope, we pushed the tube anteriorly so that we could see those lesions, and then remove these papillomas. Now this same patient had a cyst in the vallecula. So I think if all of you saw the live surgical workshop, the cyst like this was removed with coablation. We've removed this cyst with CO2 laser. And that's the post-op, video. This is day 1. Hemangiomatous polyps. Now, a few things I think which should be taken care of here is, if you see the blood vessels supplying the polyp. Sometimes you can coagulate these blood vessels using the laser on a defocused mode to fulgurize these vessels so that the bleeding does not happen when you dissect, when you make your incision. I'll play this video again. So here with the polyp is removed in such a way so that we've preserved the mucosa, and then in the end we will reposit as much as mucosa which is left back, so that you can see here with the suction. So in most of these lesions, I think that's the principle, to remove the lesion, not remove excess of the tissue, excess of the mucosa. Okay, this is a very, very small papilloma. I've purposely kept this slide because the lesion is so small. It is very, very easy to remove more than what is needed. So I think the real talent of a laser surgeon is to remove lesions like this, where you should not do more. You can see the left quad had a contact lesion, and we just fulgurized it with a laser beam on a defocused mode. So if you don't remove excess of the tissue, the healing is really good, and the voice quality is as good as normal. These are two cases of internal laryngoscale. Here we are using laser at 10 watts and a continuous mode to remove the laryngoscales. And the same patient had Rinke's edema on the other cord. I forgot to mention this. So we gave a linear incision over the cord with laser. Okay, I'll just skip this because these are two cases of varicose lesions. So I will not talk much about this because Dr. Gandhi has already showed us. So this last case is a case of sulcus vocalis. We treated the patient with therapy, and he was adamant to get some treatment done. He wanted his voice quality to be better. So we did the surgery for him. We gave 2 linear incisions. When we put the laryngoscope, we realized that there was a small cyst here on the right cord. We gave 2 linear incisions, elevated the mucosa of the cords. The cyst on the right cord was removed, which we had not seen during the stroboscopy. We removed that, and then fat was injected on both the sides in the paraglottic space. Okay, sorry, I had one more video. Kashimas. We saw live surgery of Kashimas by Dr. Gandhi a day before yesterday. So here again, we use the beam on a continuous mode, 10 watts, a linear beam, to do a posterior cordectomy. And now in most of our patients, Dr. Ramalingam gave us this idea, and we suture the cord. Once we remove the posterior part of the cord, we suture because the healing is much better and faster. There is less of crusting, and slough formation is lesser. So we have done, I think, more than 500 cases in our center. A lot of polyps, cysts, subglottic stenosis, granulations in the subglottic area, Kashimas, sulcus vocalis. We regularly keep getting patients of recurrent respiratory papillomatosis, papillomas, and laryngeal webs. So concluding my talk, I would just like to highlight the fact that CO2 laser is a great tool. It makes your outcomes better, but the only caution is that it should be used once you are well trained and you understand the hazards associated with it, and you take care of all the hazards which can happen with the CO2 laser. And once you use CO2 laser with all the precautions and the technique and expertise, there is no stopping you. Thank you.
Nice talk by Dr. Neha. I would request if the audience has any questions. Yeah, so I'd like to ask Neha that when we do the suture lateralization after the Kashimas, it's majorly to lateralize the cord?
No. We have already removed it.
Yeah.
It is just to approximate the mucosa so that it's not a bare area.
Okay. So basically, yeah. So basically, you make the anterior part of the vocal cord, the anterior edge, and you again suture it back to the
superior and the inferior.
superior and the inferior edge. Okay. After laser resection, huh? That's.
So that raw surface is minimal and granulation formation won't be there and healing will be faster.
Nice. So the suture doesn't come out. It is like basically inside the knot is inside only. Yeah. Got it. So thank you, Dr. Neha, for this nice lecture on the lesions in benign laryngeal lesions. Now I would request Brigadier Dr. Ramalingam sir to reach the dais for his presentation. Dr. Brigadier Ramalingam sir is a professor and senior director. He is currently heading the Department of ENT and Head Neck Surgery at BLK Max Super Speciality Hospital. He is a decorated officer in the Armed Forces of India with more than 30 years of experience, and he has been a professor at AFMC Pune, at Army College of Medical Sciences Delhi, and he has been the head of the Army R&R Research Referral Hospital, which is the most apex body in our armed forces, and he's been a founder member of reputed associations. He's a life member of the Association of Otolaryngologists of India. He's been a founder member of the Head and Neck Oncology, and he's been a life member of the Association of Phonosurgeons of India, and past president of Laryngology and Voice Association. He's been actively engaged in all sorts of ENT and head neck surgery, along with phonosurgery, skull-based surgery, CO2 laser surgeries, endoscopic sinus surgery, and he's also doing TORS, trans-oral robotic surgeries as well. And he has publications in several index journals, and he has been faculty and training member for so many workshops being done around the world. He has also delivered a masterclass teaching, guest lecture and live surgery demonstration at Tashkent University Medical Sciences, Uzbekistan. And I welcome him to the dais and request him to start with this presentation today on compromised airway and its management.
Thank you, Mr. Chairperson. Good morning, ladies and gentlemen. So second day or last day of our conference is on. I'm going to talk about the compromised airway. It is really a very difficult subject because most of us, being ENT surgeons, we are only concerned about airway. That it be a pediatric group or adult group. So pediatric group is more challenging. Just to enumerate the upper airway obstruction in adults, trauma, it may be blunt neck injury or any penetrating wounds or gunshot wounds, prolonged intubation, post-tracheotomy, endotracheal burn, thermal and chemical, and certain chronic inflammatory diseases which we don't see very often, diphtheria, syphilis, tuberculosis, leprosy, sarcoidosis we have seen, scleroma we have seen, but the upper 3, 4 we have not seen. At least I have not seen. Then benign neoplasms like intrinsic papillomas, chondromas, minor salivary gland tumors, neural, extrinsic thyroid thymus which presses on the trachea. I'll be showing you a few cases where the trachea was invaded with papillary thyroid, and I did resection anastomosis of the trachea after excision of the thyroid. Malignant neoplasms, squamous cell carcinoma, minor salivary gland tumors, sarcomas, lymphomas, extrinsic thyroid, as I told you, collagen vascular disease. Then bilateral vocal cord palsy, laryngeal web, laryngotracheal stenosis. This is the main cause what we find in adults, and obstructive sleep apnea also, because these guys, they, I mean, the AHI sometimes it is 90 like that, 90, 100 we have operated on. A word about congenital subglottic stenosis in children, thought to be secondary to failure of laryngeal lumen to recanalize. Defined as subglottic diameter less than 4, full-term infant. Normal full-term infant, the subglottic diameter is about 4.5 to 5.5. Premature infant, the subglottic diameter is about 3.5. If less than 3.5, then it is subglottic stenosis. Sorry. Congenital subglottic stenosis is divided into membranous cartilaginous type. Membranous is soft tissue thickening from fibrous connective tissue or hyperplastic submucous glands, and it may involve the vocal folds. Cartilage usually arises from thickened or malformed cricoid cartilage. Usually large anterior subglottic shelf leaving only a small airway posteriorly. It can be due to elliptical shaped cricoid cartilage. Membranous type usually less severe than the cartilaginous. Cartilaginous is very difficult to deal with also. So again, severity depends on the degree of narrowing. Symptoms can range from mild with picture of recurrent coo or severe with distress at delivery. We recently, about 2 months back, I operated on a small baby, was getting admitted recurrent with recurrent pneumonitis. The child was actually having aspiration. So they wanted to do, they found that the pulmonologist that there is tracheomalacia, so they wanted to do autopexy, but they could not intubate. Dr. Neha was called, I was away, Dr. Neha was called to do emergency tracheostomy, and she did, save the child. Later on, when I examined, I found it was grade 2 to grade 3 subglottic stenosis. That's why the tube was not able to go. So we had to do laser surgery and then balloon dilatation. Subsequently, child became all right, then went for autopexy. Last week, she underwent autopexy. Acquired subglottic stenosis, intubation is the most common. Then most common is endotracheal intubation, as I told you. And in the premature infants, since more premature infants are surviving, the incidence of acquired stenosis has increased because most of the time the babies, they require intubation, prolonged intubation. I'll tell you, up to 50 days you can. In a small baby, they can tolerate the intubation. After that, you have to decide whether to do a tracheostomy or not. So these are the risk factors in the neonates. And the most important factor, length of the intubation, that's what I've told you, that there is no safe period for intubation. But it has been suggested that tracheostomy should be considered after 50 days of intubation in neonates. interesting cases. This is supraglottic stenosis, grade 4. As you can see, there is hardly any lumen. And this is idiopathic subglottic stenosis. We don't know. This patient came with respiratory distress. We did the scopy and we found there was a subglottic growth, stenosis rather. So we thought we'll do dilatation and we'll get away. No, the patient again within 1 month it recurred. So I had to take biopsy, and the patient went from one hospital to another hospital, including AIMS. So everybody had different opinions because our pathologist also could not find out what is actually the real cause. He was having multiple problems. And finally, we again reviewed all the slides and put our heads together, and we found that it is IgG4 related disease. And patient is on methotrexate and all that. This is a balloon dilatation in a small child. This is our team of airway team. I'll just show you. Me and Neha, we are mostly involved in airway management, and the pediatric pulmonologist, PICU in charge. So this 2 months old baby was on ventilator for 10 days. Was on ventilator for meconium aspiration syndrome. And then when she came, the child had grade 3 stenosis, you can see. And we used MLW wand first, and then tablet collaborator. That is also another very useful wand to give a cut. You have to give Mercedes Benz incision in the stenotic membrane. This we are doing after using the tablet wand. And then we also used RF, radio frequency. So unless you give the incision, you cannot dilate. So we use the dilator. I get it from cardiac OT, like those people who they are using our vascular surgeons. They are using dilators. So those balloons I take free of cost, used balloons and autoclaved. We inflate the balloon on at least 10 to 12 atmospheric pressure and leave it for 40 seconds. And later on, we inject Kenacort and also apply mitomycin C. So now this Cynoventuala balloon we used, which you use for balloon sinoplasty. So now you can see it has opened up nicely. This baby we could get away by doing only once dilatation. Sometimes the children may require 2-3 dilatations. People advocate that up to 5 dilatations also you can continue. After 5th dilatation, if the child is having recurrence, then you have to think of other modality like stenting with T-tube or resection anastomosis and all that. This is the RF we're using to give the cuts. Again, balloon dilatation. So this is very interesting. I want to share with you. When I was in R&R hospital, can you see this is right main bronchus completely occluded by carcinoid tumor. Carcinoid tumor is locally, it is a very slow growing disease. So this lady came with a lot of breathlessness and dyspnea. So we used KTP laser. We first sitting, we could make some airway. Then we took another 3-4 sittings to remove the entire tumor from the right main bronchus. However, there was in the lung parenchyma, there was the disease, but she was already 70 years old. Nobody wanted to touch her. They said, "You establish the airway and leave it." So she kept on coming back to us, and she did well. Now, this is another very interesting. This patient came from Africa. He had again carcinoma tumor. Completely, if you see the entire tumor, including right main bronchus and the spilling onto left main bronchus. When I'll show you the picture, you will realize how the child was. It was about 15 years old boy. There's no space. My anesthetist, he said, "Sorry, boss, we can't give GA." Well, I said, "I don't want GA. You just be there in case it is required." So you can't see, in the left main bronchus, you can see that there is a little bit, carina is not visible. So we used diode laser and kept on cutting. After 3 sittings, we cleared and everything was done under local anesthesia. After 3 sittings, we could achieve this, and the child was cooperative. We didn't even sedate him. If you see the lower one here, now you can see the carina, and it is limited to the right main bronchus. Subsequently, he underwent pneumonectomy on this side. Another young boy, 10 years old boy, he came with recurrent papilloma of trachea. So just see, the child was not able to sleep. He used to sleep in sitting position only. So when the child was shown to me, I said I can remove with diode laser. The PICU in charge didn't believe. So when I was doing in the OT, he gathered everybody, CTVS, anesthetist, everybody. There were 10 people standing behind me. So I said, "We have done and we'll do it." You can't see left main bronchus, only right main bronchus. We used diode laser. I took about 5 hours in single go. We operated. Painstakingly kept on ablating, fulgurizing the tissue. And this is third post-op day video. You can see the left main bronchus completely, and this is all charred tissue where there is no tumor. Sometimes, when you do tracheal resection anastomosis, particularly when we used to put Prolin sutures earlier, you get this kind of granulations. What you do? We use KTP laser and fulgurize those granulations. This lady came from Barot. It was a suicidal attempt. She slit her throat. It just got cut above the level of vocal cords. And the patient came after 8 hours to my center. When I was called to see in the emergency, I was really aghast how she could do it. We put the tracheostomy tube. Then we investigated. We found out that it's a clean cut. So we did end-to-end anastomosis of the thyroid cartilage. and she did well after that. The few, like you get this exuberant laryngeal papillomatosis, as Dr. Neha also showed in her videos. We use CO2 laser, that's the best, and sometimes we use the adenodectomy wand also, coablator also. So, sorry, I have to rush through. Once you remove everything, then you will find this is all in the false chord area. And we started injecting the Avastin, is very good. Can you see the, sorry, there was a, I mean, the cord was free. This patient came with a very thin fibrotic band. Can you see? It was not causing much of problem, but he was not having a clear speech, so he wanted to, he was an adult. So we did with AVEC only, we did with fiber, laser fiber, we cut it. And this is the post-op. Now, let's come to laryngotracheal stenosis. Little bit of anatomy. The adult airway from true vocal cords to the carina measures about 13 to 15 centimeter. And the first 2 centimeters of cartilage from subglottic space. From the lower edge of the cricoid to the carinal sphere, the trachea therefore measures about 11 centimeter, and there are 18 to 22 rings, and 50% rings become cervical when you do proper extension. And that 50% you can remove also with laryngeal drop and mobilization of the trachea. Suprahyoid laryngeal release, it gives about 1.5 centimeter, the larynx drops, and with neck flexion and pulling, mobilizing, then you get another 4.5 centimeters. So I have removed 5 centimeter stenotic segment also, and there is no problem. In older patients, the release is required if it is just 2 centimeter also, because the neck is not very pliable. There is no universal classification system, but we follow Mayer Cotton or Cotton Mayers and McAfee. McAfee, this is actually, I follow both. Why I am telling you? When you are dealing tracheal stenosis, it is not only grade of obstruction, but also it is the length which is required. Because you have to form a 3-dimensional view. You are not looking at only how much is the narrowing, but how much length of the trachea is involved. That is very important. So, McAfee, it is stage 1, 1 centimeter, stage 2, more than 1 centimeter, stage 3, confined to trachea and subglottis, sparing glottis, stage 4, glottic involvement. Glottic involvement, very difficult to treat. Mayer Cotton, simple, less than 50%, grade 1, 50 to 75, grade 2, 76 to 99, grade 3. When there is no lumen, it is grade 4. This is how it is. I will show you how grade 1 stenosis, you don't have to do anything, no need to sweat over it. And grade 2, sometimes you have to do it. Grade 3, this one, if you see. And this is grade 4. You see, the secretions are not going down at all. This patient came from Arunachal Pradesh. I had operated. Like pathogenesis, what happens actually? The intubation trauma and all, how it leads to tracheal stenosis. Mucosal or cartilaginous injury results in inflammatory response, and subsequently remodeling is that is healing with secondary intention, and ultimately the scarring due to fibrosis. These are the four distal lesions where your intubation trauma can occur, and we have seen glottis, subglottis, the stomal area you can have, and tracheomalacia can occur. I have seen in suprastomal as well as intrastomal. What I do when I find that there is a tracheomalacia suprastomal, I take a 2O Prolene suture and anchor it in the skin permanently. That gives a good airway. Now, ideal endotracheal tube should allow air leak at pressure of 20 centimeter. So, if there is audible air leak is not there, that means the tube is oversized. You should avoid. Tube motion. Have you ever seen in ICU how this ventilator setting works? The endotracheal tube, it is connected to the arm of the ventilator. Now, when it is working and when the patient is breathing, there is, unless it is secured very nicely, the tube keeps on moving. Maybe 2 millimeter, 3 millimeter, but it is moving and it is causing abrasion. So I always tell the critical care people, please be careful about this particular thing. Otherwise, this guy is going to land up with me for tracheal stenosis. Repeated intubation should be minimized. In our setup, mostly the MSU people, they say that once or twice they give a chance for extubation. If it is not there, then they call us for tracheostomy. Surfactant, it is in the NICU and PICU they use mostly. So this is the incidence usually. So as I told you, chondritis and final deposition of fibrous material. These are few images I am showing, then I'll show you the actual. This is supraglottic, supralaryngeal release and resection anastomosis here. In the afternoon, we'll be demonstrating you on sheep trachea how to do tracheal resection anastomosis. Sometimes if it is down below in the thoracic inlet, then you have to do a T-shaped incision and open the thorax to mobilize the trachea. This is what it is. This is the tracheal resection anastomosis. Simple. You give transverse incision, and here we have given the exposure. Then I'll be showing you endotracheal tube is passed from above through nose, and then this is the defect. We close, and I used to give sternomental sutures earlier, but since last 15 years we stopped because it's not of much use. Now, recently, these are the last 2-3 years photographs. This is again, endotracheal tube is there. This is the defect and is about 4 centimeter. We did suprahyoid release and mobilization. How you mobilize? Anteriorly to the trachea, hug the trachea and dissect and go up to the carina, and posteriorly between the esophagus and trachea, you have to insunate your finger. Don't go laterally because the blood supply of trachea is from lateral side. So anteriorly and posteriorly you can go up to carina. We feel it and then pull. The trachea comes up. At least 3 centimeters it comes up. So this is what, and take posterior sutures first and then then pass the tube, endotracheal tube down below, and then lateral sutures and then subsequently anterior sutures. This is how it is. This is cricotracheothyropexy. Recently I had been to Bangladesh. There they told that it is at second ring, but when I actually opened, I found that it was involving the cricoid cartilage as well. So I had to cut the cricoid cartilage and we did the cricotracheothyropexy. This is how it is. Here, this one is mobilized upwards. We moved upwards and we sutured it. This is cricotracheothyropexy. Can you see? This is the cricoid cartilage, which is wide open, and then we mobilize and we anastomose. We have also done posterior cricoid split. In subaortic stenosis, you put rib cartilage in the posterior cricoid area. This is the rib cartilage and secure it. And then anteriorly also, you have to put, this is the anterior portion now. We take a boat-shaped rib cartilage and put it here, and it has to be stented. And after 1 month, you can remove the stent. This is total thyroidectomy and tracheal resection because this was involving the trachea. Here you see the operative picture. This is the total thyroidectomy done. And after removal, this is recurrent laryngeal nerves, you can see. And then we did the resection anastomosis, complete anastomosis. Suprahyoid laryngeal drop. How you do? Feel the body. Above it, you with cautery, you cut all the muscles. And on either side of the body, you cut it with a bone cutter, small bone cutter, and immediately it drops down. And end-to-end anastomosis was performed. This is again a very old picture. She had a thyroid malignancy involving the trachea. So, to conclude, firstly, prevent. How to prevent? You have to educate others. Secondly, preserve as much as possible normal tracheal rings. And the timing of tracheal repair also it should be very ideal, because what happens sometimes subaortic stenosis, you want to do the posterior cricoid split and all, then you have to think, yes, I can, if I can do, I will do it. Otherwise, you can do sometimes balloon dilatation and wait for 2-3 months. If the dilatation is successful, then you can do a resection anastomosis. It is actually very coordinated approach. Here, anesthetist has to be taken into confidence that yes, you have to put a tube through nose and keep it there at the laryngeal inlet. When I say, then you push it down. And then afterwards, the critical care specialist, because for 24 hours, patient has to be kept intubated. So critical care specialists, they come. And thoracic surgeon is required if you have to open the thorax. Thank you.
Thank you, Dr. Ramalingam, sir, for the excellent talk. And may I ask the audience for any questions if they have? We are maybe running.
Yeah.
Good morning, Dr. Ramalingam.
Morning, Dr. Vas, welcome.
It's a very nice presentation. One question is, do you use brighter sometimes? Schema brain?
So far, I have never used. Particularly, you are talking about RRP?
Yes.
I have never used. Rather, I have used coblator and laser. People have used microdebrider for cutting the papilloma. Sorry? I have not done. I am honest with you.
I was observing that steamer blades, they are being used in the trachea and the larynx also, trachea also, and the trachea also.
Yeah, I know. Yeah.
Yeah.
What is the kind of stent you use? Suppose it is cut like that.
What I generally do is, I take Montgomery T tube, I cut the lower end and put it inside, and then secure it from outside, and I remove after 1 or 2 months or so. You have to just cut from outside, and through putting a bronchoscope, you can remove it.
Will have a tube.
No, no, no. Tracheostomy tube will be there. Tracheostomy tube will be there. You are stenting upper portion. Particularly when you are using rib cartilage. Some people, they don't do it, but I prefer to be safe. In corporate sector, you have to be safe. Otherwise, you will be sued.
Then how about the traveling after thyroid?
Nothing happens. They do perfectly well.
Even if we cut out
Nothing happens.
So
Thank you
Dr.
very much. I think we have to go for the other session. Huh?
Yeah.
I would like to call Dr. Neha Soot to please felicitate the chairperson. Dr. Manish Prakash and Dr. Bhushan. Dr. Bhushan Patil. Going for the next session, I would like to invite the chairperson, Dr. Devinder Rai and Dr. Surya Schwartz to chair the next session.
Probably yes. We don't want it to be. Hi, David. Hi, David. Can you hear us?
Hello, yes, I can hear you. Can you hear me?
Hi, David.
Can you hear me now?
Hi, David. Can you hear us?
Yes, I can hear you loud and clear, Dr. Ramalingam.
Hello.
Can you hear me?
Hi. Sound. उनका sound आ रहा है? अच्छा, okay.
Dr. David, here's a good morning. I don't know what time it is there, what kind of situation is happening there at the moment, but it's still
It's 12:30 here.
okay, 4:30 in the night.
In the afternoon. We're 2.5 hours ahead of you.
Right, it's pretty pleasant then for you,
Yes.
for us, of course.
Yes.
But we very honored that you're here with us, giving your lecture and your oration. And I would just like to introduce you to the people who are gathered here. Is that you are a visiting consultant at the Singapore General Hospital and Raffles Hospital, and you're an ENT surgeon with over 18 years in this specialty, and having worked in the UK, Canada, and Singapore. That's pretty wide, I must say. And of course, you have a lot of local and international experience. And you had a training in the UK, St. Mary's Hospital, London, Hospital of Sick Children, Great Ormond Street, which is really fantastic, and the prestigious Edinburgh's Hospital in Cambridge. And you received your FRCS from Edinburgh in 1996. And there we are. And I think with this presentation, we welcome you again, and we request you to go ahead with the presentation. Dr. David,
Thank you very much.
Thank you.
And I would like to thank Dr. Ramalingam for inviting me. and also for this opportunity to be able to present online. I'm going to share my screen now.
Right.
We'll share the sound.
Right.
Okay. Are you able to see the screen?
Absolutely.
Okay, that's great. I can actually see a clip of it myself.
Right.
So I'm going to talk about the approach to a patient with swallowing disorder. And managing patients with swallowing disorders can at first seem a little bit difficult to do, but it can be extremely satisfying. And some of my most grateful patients have actually been patients who we've done simple things with to improve their swallowing. So who are we referring to when we talk about a patient with a swallowing disorder? We're essentially talking about patients not just with swallowing problems, but who are also
Sorry, I think we just missed out on your.
Oh, okay.
I probably have to go back to it again. Is any IT person?
Let me reshare. Sorry, I think the connection seemed to cut off for a while.
Yeah. Thank you.
Are you able to see? Can you see
Yes.
now? Okay. Hopefully it'll stay steady.
Yeah.
So we're talking about patients with swallowing problems, risk of aspiration pneumonia. Examples of these would be neurological conditions, head and neck cancer, very often after radiotherapy or surgery. Sometimes patients simply with recurrent chest infections. And sometimes patients can present simply with frequent coughing or choking. These patients may be adults, they may be children. So how do we approach the patient? How is it done? First of all, we have to understand the physiology of the normal swallow in order to understand and accurately diagnose a swallowing disorder. And I will just run through some of the phases of the normal swallow. So we start with the oral preparatory phase where we chew the food. We manipulate the bolus back into the tongue, back into the mouth using the tongue and the palate. The food bolus then passes into the oropharynx and into the esophagus. It is the oropharyngeal phase that is the most critical because this is where the digestive tract and the airway intersect most critically. There are a number of steps that take place that we have to be aware of. The first of these, and all of these occur in very close succession to each other and often simultaneously. So the first of these is vocal fold closure. After the vocal folds close, the soft palate elevates to close off the oropharynx from the nasopharynx. The tongue base then propels upwards and backwards and pushes the food bolus backwards. The larynx is then drawn upwards, and at the same time, the epiglottis retroverts and covers the glottis. And when the larynx is elevated, the cricopharyngeal sphincter relaxes and is pulled open. The pharyngeal muscles then contract and push the food bolus into the esophagus. If we look at some corresponding endoscopic still pictures, this is what we can see. So first of all, the vocal folds, and you're looking at the arytenoids here. The vocal folds are closing. The tongue base then elevates posteriorly. The larynx is then elevated, and together with this is the important whiteout. So everything turns white, and this is an important visualization of the normal swallow. The epiglottis has retroverted here, and when it does, the food is able to slide over the epiglottis, and subsequently the epiglottis flips back over again. We can assess the cricopharyngeal function by looking at pooling, and that pooling takes place here in the piriform fossa. Now, if we look at a dynamic view of what is going on, this video on the left side is basically what we see. And this is a looped video. So if you blink, you miss it. And essentially, a lot of what you're seeing here is the picture on the right, which is the whiteout. And when we see a good whiteout, generally the swallowing is in good shape. What are we actually trying to find out from all of this? We're trying to find out what is the risk of aspiration. Can the patient be fed safely? Can function be restored and or rehabilitated? And would surgery help? And what modalities do we have that are available to assess these functions? We can do a bedside examination. We can do a flexible endoscopic evaluation of swallowing. We can do a fluoroscopic swallowing assessment. Or, and sometimes in combination, we may also do a transnasal esophagoscopy to look at the esophagus. And I think there was a talk on this yesterday. How useful is the humble bedside examination? It does have a role. It uses or it assesses the airway response by looking at coughing and choking and voice changes, whether there's a wet and gurgly voice, to identify the presence of aspiration. It can be a useful screening test. So for example, if we're giving the patient small volumes of liquid and they have clinical signs, then aspiration is highly likely, and swallowing has to proceed very carefully. Sometimes auscultation may be used with a stethoscope to assess some of the voice changes. What are the advantages of the flexible endoscopic evaluation of swallowing? It allows direct visualization. We use a flexible nasal endoscope, and we give colored food and drink of different consistencies, and it is portable. So we can do it by the bedside. We can use it to assess facilitative strategies. So some of these might include altering or modifying the bolus, for example, using thickeners, and very often we use actual foods of different consistencies. We can assess the effect of behavioral changes, for example, using multiple swallows or washing down residue with thickened liquid. We can assess postural measures, for example, chin tuck during swallow, and sometimes actually having video feedback during the examination can help not only the patient, but also the caregivers understand what is involved and what is necessary. So this is just a video clip of a patient's swallow to show the effect of thickening. Now, the video clip which is playing on the left shows a patient who's had a stroke. And what you're seeing here is something known as premature spillage. So the fluid is spilling all the way down to the piriform fossa, and the patient still hasn't initiated a swallow. Normally, there should be a reflex swallow by this stage. And you can see that they're attempting to swallow. Eventually, they do so. And what happens is that there is some penetration and aspiration into the larynx and the upper trachea. Okay, and they're coughing out the green liquid. If we then look at the video on the right-hand side, the fluid has now simply been thickened a little bit, and there's still not a very good reflex to initiating the swallow. So in other words, there's still premature spillage all the way down to the piriform fossa. But when the patient swallows, they're able to swallow the bolus completely without any penetration or aspiration. So a simple measure and a very nice solution. Access to fees for patients after a stroke has been shown to significantly reduce pneumonia rates because you're able to detect a swallowing problem, you're able to manage it early. Patients who undergo fees are more likely to leave hospital on a standard diet after a stroke, and this can all result in improved functional outcomes for the patient. Fees can be used in infants. So, for example, infants who have feeding difficulties, noisy breathing with feeding, cyanosis with feeding, it can be used safely and effectively even in under 1 year of age. It is the only assessment modality that can be used during active breastfeeding. Cooperation obviously can be an issue, although people who have studied this suggest that the success rates can be quite high, even with a median age of around 2 years old. Now, what if we compare fees, endoscopic evaluation of swallowing, and video fluoroscopic swallowing studies? Which is the gold standard? So this is a little clip of a VFSS taking place. Essentially, this is a dynamic evaluation of swallowing using barium sulfate and imaging, fluoroscopic imaging. It has been considered to be the gold standard since the early 70s. However, it does involve radiation, although this radiation is not considered excessive, and it is cumbersome. You can see that the equipment is quite bulky, and it is expensive. What about flexible endoscopic evaluation of swallow? So again, this allows direct visualization. It is mobile, there's no radiation, and there's less cost. And it also allows an additional testing modality, which is sensory testing. And we can either do this by using the endoscope to pump air onto the larynx, or sometimes even using the endoscope itself just to touch structures. Okay, so there has been a consensus statement regarding the comparison between fees and VFSS. And the consensus is generally that fees is more likely or more sensitive for the presence of aspiration because we can actually see it physically. So small amounts will be detected. Sorry. It is also more sensitive for detecting oropharyngeal food residue, and it's easier to use and more accessible. Now, this is a picture or a video clip of a VFSS in a patient who has cricopharyngeal dysfunction. And VFSS can, in fact, be more helpful to determine cricopharyngeal dysfunction. This is a patient who has dermatomyositis and a tight cricopharyngeal sphincter. And if we look at the video clip, they're trying to swallow. So we're looking at the clip on the left. They're trying to swallow the barium, and it's not going through because the cricopharynx is excessively tight, and you can see that very well on the video fluoroscopy. Eventually, it does open, and some barium passes through. Now, in this patient, we did a dilatation, and we injected Botox into the cricopharyngeal sphincter. And if you now look at the video on the right, you can see when they swallow, immediately the bolus passes through the cricopharynx into the esophagus. In fees, the cricopharyngeal sphincter opening is inferred by looking at pooling. So this, and these are stills, these are not videos. So this is a patient who has had nasopharyngeal cancer and is post-radiation therapy. And when we look into the larynx, we can see that there's a lot of pooling of secretions in the hypopharynx. And this is essentially not because of muscle spasm, as in the previous case, but because of fibrosis. And some of these patients can be helped by dilating the cricopharyngeal sphincter. And you can see in the picture on the right side, that dilatation, they're able to clear the secretions better. I'm just going to end this segment now with a just to show you a case of a patient who has aspiration pneumonia but has a normal fees. And what we then carried out a video fluoroscopy, and this showed significant aspiration, and this was actually found to be due to a tracheoesophageal fistula, which was a result of mediastinal lymphoma. So clearly this would not have been picked up on the fees. And this just helps to illustrate that video fluoroscopy and fees are often complementary. I'm just going to end with two video clips of two procedures that we do that I find work very nicely in patients with swallowing issues. And one of my most grateful patients is actually someone who had a skull base fracture and a vagal nerve injury, and ended up with glottic insufficiency. And I corrected his glottic insufficiency, and he was actually able to swallow and able to rehabilitate his swallow really well after that. And I'm just going to show this 2-minute video clip here. So this is actually a different patient who has a left-sided paralysis. This is a patient who's had radiation therapy after nasopharyngeal cancer, and he's unable to close his glottis, and he's getting recurrent aspiration pneumonia. And we're doing a transthyrohyoid injection medialization. What we're doing here is using a fine needle to spray anesthetic onto the vocal folds. And many of these patients also have somewhat reduced sensation as well, because the insult to the vagal nerve has been at the skull base. But nonetheless, it helps to apply some local anesthetic. And then we're using a doubly bent 25 gauge needle, and we're guiding it with the flexible endoscope through the nose, and we're aiming now for the back of the left vocal fold at the junction of the membranous and the cartilaginous fold. And we can use the needle to reflect the ventricle or the ventricular fold. And you can see that the way that the endoscope is positioned and rotated is very important in order to get the correct visualization. And this is an unedited video. So we've now found the spot that we want to inject, and we're starting to inject the filler. The tissue after radiation therapy is a little bit fibrosed. Okay, at first nothing seems to happen, but then you start to see that some bulging is starting to take place now in the vocal fold. And the vocal fold is now starting to bulge up very nicely. And you can see that the patient is now able to oppose both of the vocal folds together. And I'm using hyaluronic acid here to fill the vocal fold. Okay, so you can see he can close his glottis normally now. Okay, and I've just got one more short video of the other type of procedure that we more commonly do, and that is dilatation of the cricopharyngeal sphincter. And here I'm using a flexible endoscope to do the procedure with a therapeutic channel. So you can see this patient has a lot of saliva pooling, and we're vacuuming this away with the therapeutic endoscope. You can use a transnasal endoscope to do this. We then pass a guide wire through the channel, and we can guide this directly into the esophagus. So this patient has a tight cricopharyngeal sphincter, and we then remove the endoscope and railroad the balloon dilator over the guide wire, and the endoscope is used parallel to the wire, and you can see that the balloon can be positioned exactly where you want it to be. And we're then dilating it to 2 centimeters, and we do this for a minute, and typically I will repeat this 2 or 3 times. And then once we're done, we remove everything, and that's the end of the procedure. Okay, and I'm going to stop my talk there. Thank you very much.
Dr. Law, that was an amazing presentation, of course. And I think that you just reiterated a very simple thing, that a fees scores so much over the VFSSS with all the advantages that the fees definitely has. And I think the take-home message of this conference should be that let's do things which are simple and some things that ENT people can do. So I am happy that you have given that message. It's total resounding academic background also. Thank you very much. I have with me Dr. Suresh Watts as my co-chairman. If he has any comments or if there's anyone else to make a comment. Dr. Sachin is there. Sachin, welcome. And he has comments to make.
Yeah. Thank you, David. It's Dr. Sachin Gandhi.
Thank you, Sachin. Nice to see you again.
Thank you. Yeah, good. Yeah. See you next week.
Yes, definitely. Yeah, look forward to it.
I think you guys keep on meeting on different centers. Good. Thank you, sir. Thank you very much.
Thank you. Thank you.
Who's the person? Yeah. Next person. Oh.
Good morning, Dr. Deepak Mehta. Can you hear me?
Good morning. Yes, good morning.
It is morning here. I don't know. It must be.
It's night here. It's night here.
Dr. Deepak Kumar, Deepak Mehta, he is presently working as a professor at Bayer's College of Medicine, Houston. He has worked at the University of Pittsburgh, University of School of Medicine as an assistant professor, and at the University of Cincinnati, and at the University of Nottingham as a clinical instructor. He has been awarded with the various honors like American Academy of Otolaryngology, Head and Neck Cancer, Neck Surgery Honors Award, Sylvan Stool Award for Excellence in Teaching, Society for the Ear, Nose and Throat, in children. Denton A. Cooley Fellowship in Surgical Innovation Award in 2017 and 18. In Melvin Scholars Lecture in Pediatric Otolaryngology awarded by McGill University, Montreal, Canada. I invite you, sir, for your oration on chasing complications to improve outcomes, a LTR story. Dr. Deepak Mehta, sir.
Thank you. Thank you very much. Thank you for the organizers for inviting me. It's a bigger honor because I'm giving the Oswald oration lecture. Mr. Oswald was one of my heroes because first time when I moved to England and my first job, I was actually a volunteer for one of his courses, helping put together some of the cases for live surgery. So it goes back to those times. So I'm honored that I'm giving this lecture because Mr. Oswald was a pioneer. He was a leader in especially use of lasers in surgery. He was ahead of his time and a great educator. So with that, what I'm trying to do with this talk is trying to, one, give us a little background on history on how laryngotracheal reconstruction happened in pediatric age group, and also to see where we are and what we can do to make things better for these kids. So as we know, subglottic stenosis, there are various causes for subglottic stenosis, but the commonest cause is acquired, which is in most of these patients. And what happens is, in the talk earlier, it was showed how subglottic stenosis happens. But when you go back, hear about Chevalier Jackson, he's considered father of bronchoesophagology. And he, in 1936, stated that laryngotracheal stenosis was curable in children. And what he was doing was using rubber core molds to repeatedly dilate. So basically open up the larynx and put those molds in there and change them every weekly basis or sometimes twice weekly. But his main thing was, he said, never divide the cricoid. So when someone of his caliber said, never divide the cricoid, that went on for many years because people were afraid to open up the cricoid for many, many years. But what happened was, in those days, they would do a median vertical fissure, provided the airway, they'll put the dilating tubes, and multiple times daily, it would be done. So these are some of the example of some of the molds which were being used. So what happened between 30s and 70s is the epidemiology of laryngeal stenosis changed, and mainly because antibiotics came in, vaccines came in, because before that it was all because of infection, whether it was diphtheria, tuberculosis, all those were causing. And then once all that came, what happened was the motor vehicle era came. So a lot of traumatic subglottic stenosis and adult subglottic stenosis happened in that era. And during that time, also, people were coming up with new ways of dealing with this. So the first time use of rib cartilage was described by Montgomery, and then Joseph Agura described subpericondral resection of the scar and thyrotracheal anastomosis. So all that was done. And then what happened was, when you go back to after 60s, from trauma being the leading cause, what happened was there was advancement of use of different things for the kids. But what happened was the newborns were being born, and there was intubation was being done on these kids, which was not before, and a lot of these kids would have died, and now they've started to intubate these kids, and that was saving these kids. But what happened was, as in the earlier talk was given, some of these kids end up getting subglottic stenosis. And why does this happen? It can happen because either there is a smaller cricoid, maybe because of endotracheal movement, maybe the tube design and material is irritating. So there can be various causes for that. And we saw that over a period of time, the the subglottic stenosis got better. And some of it was our understanding of trauma to the subglottis and how do we prevent it, but also because of some of the new innovations of using surfactant, using steroids. So better management helped. And also understanding of the tube material, tube fixation, use of non-cuff tubes, all that help to change some of the initial. So when you start to have stenosis, you start thinking, what can I do to make this better? But the changing point was when, so this was given by Cotton's lecture. What he said was they were seeing that all these kids were being saved, but at the same time, they ended up getting tracheostomy because of subglottic stenosis, and they were going home with tracheostomies and nothing could be done. And this is an example of how a trach ward used to be in Toronto, where a lot of these kids were like permanently hospitalized. And at that time, Cotton with Ferron did some studies on monkeys using of costal cartilage. So when he started off in Cincinnati as a faculty there, what he saw was the mortality rate of kids with tracheostomy was 25%. So of all the kids they would have saved and done a tracheostomy, they would go home and 25% of them would die. So for him, this was like, there's no way we can just wait and watch 25% of these kids to die. And that's when he used some of his basic science work he had done on monkeys where they used costal cartilage, so that he said, even if the mortality rate goes down by anywhere less than 25%, it's worth it. And that's how he started to do the costal cartilage graft in the anterior. It was just, he was mainly doing the anterior costal cartilage graft. And at similar time, Evans in Great Ormond Street was doing this castellated opening of the trachea, and he was getting fair results from it. But this was an important point when Cotton Evans, both were good friends, and they talk about why don't we put all our patients together and compare what happens to those results. So in that paper, it showed that the costal cartilage graft was more appropriate for severe anterior subglottic stenosis, but the Evans approach was better for posterior because at that time the posterior graft was not being done on kids. So it showed that it was probably better for those ones. But then, since then, Cotton went and learned how to do, so there was a surgeon in Budapest who was doing posterior grafts. So he went and learned posterior grafts. So he came back and introduced anterior and posterior grafting. Once he introduced that, he showed that his results were much, much better. So slowly the castellated laryngotracheoplasty went off, and Cotton's way of doing anterior and anterior-posterior graft came into effect. And what they started to show is, even in the rabbit model, initially they showed that they survived, because the worry was, why would you divide the cricoid? What will happen to it? And some of it, again, the myth was that you shouldn't be dividing the cricoid because these kids will grow and then you're shunting the growth of their airway. So that myth had to be taken off because they had to slowly show that this is not really true. And then the advancement happened is, until then, what was being done is all these procedures were being done as double-stage procedure where the tracheostomy tube was still in. And then the next advancement happened because the ICU care got better, that they started doing what is called as a single-stage laryngotracheal reconstruction, where the tracheostomy is taken out at the time of surgery, but then they'll have an endotracheal tube which acts as a stent. What they showed was the success rate was pretty good with it. But you don't stop there. Just because you have 80% success rate, you don't stop. So then in 2001, the paper from Cincinnati, again from Cotton's group, came showing that overall success rate was still in double stage LTR for grade 3 and 4 was not as good. And some of these needed multiple reconstructive surgery. So they were like, how can we do better with this? But what was happening at the same time was the group in Europe, mainly led by Monnier, showed that you could do cricotracheal resection. And what they showed was the cricotracheal resection where the anterior cricoid is taken and then the scar tissue is removed and then the two ends are brought together, showed that their results were better, especially for the grade 3s and 4s, where the results decannulation rate was 95%. And even for salvage procedures where the LTR had failed, they got pretty good results. So that was good. And even extended cricotracheal resection where they would use a graft for the posterior glottic stenosis, even those, the results were way better than laryngotracheal reconstruction. So does it mean this will take over? No, that becomes part of your armamentarium of what are the different things you can do with airway reconstruction. So you can either augment or you can resect. And the other thing which came into play is the tracheal slide. So you have these options of either doing anterior-posterior grafts, you can do cricotracheal resection, and any of these you can do single stage or double stage. And this is an example of how an anterior graft sits in and a posterior graft, and again, you can do single stage or double stage. But at that point, people start to think like, how can we make better of our results when you have a situation where it works in 80%, but you need to start to think, why did it not work in my 20%? So what can I do to make those 20% better in those 20% as well? And that's where the Aerodigestive Centers was first started in Cincinnati, and now it's there in many places. But what it did was, it was looking at dynamic airway to see if there was residual tracheomalacia, there was something else going on. They were looking at swallowing and voice. They were looking at aspiration because maybe the patient was still aspirating. And the other thing was the GI tract came into effect because they were looking at residual reflux where the reflux was not identified or not properly treated, or a new disease at that time was a eosinophilic esophagitis, which was allergy of the esophagus. And what it showed was, once they started to see that, the success rate for first-time surgery got better from 50 to 60% to 75%, and overall success rate was 87%. So they started to pick up some of those patients where they were feeling they were not fully assessed and might have missed something. They started picking those up and fixing them help. And what also showed was some of the, again, the other way to look at it is they looked at the failures, and some of the failures, and this paper from Cincinnati showed that a majority of the failures were because of infection. And when you look at infection, the commonest thing was MRSA or Pseudomonas. So then what came from it was to do a pre-surgery assessment of their stoma, nasal cavity, and take a swab and see what they grow. And if they grow MRSA or Pseudomonas, they are adequately treated pre-operatively and they are treated perioperatively so that that factor is removed so that the incidence of infection goes. And again, from that paper, it showed that the prevalence of MRSA or any infection went from 32% to 0. So it made a big difference in some of the results. And this is me with cotton after my fellowship. And so when I started my practice, basically some of these things, again, you work on what you've learned from your mentors, and some of the work is already done over the years. So when I started my practice of doing airway reconstructions, what I did was basically use all these things which was going on and created a structure of how every patient is assessed. So every patient walks in, they'll have a triple endoscopy, which means a GI, pulmonology sees, make sure they're ready for the surgery. They all get swabbed. They are all treated appropriately. And what we showed was the success rate, and this is for first-time surgery. It's not revision surgery, just doing first-time surgery. We showed that the success rate could be higher, even better than just cricotracheal resection. And it doesn't mean one surgery is superior or inferior. It basically means once you start looking at what are the factors for failure, you can improve your success rate. And same thing happens when you move from one institution which has a certain way of doing things, and that could happen to any of us when you have ICUs. People talk about this is how I do in my place. But again, you need to look at what you have in your center, and sometimes you might have to make changes in your institution to make that happen. And same thing happened to me where when I moved, I had a situation where the ICU needed education to say how would he take care of these patients if he want to do a single stage laryngotracheal reconstruction. And some of it is standardizing the care to say how do you sedate them, when do you get them ready for extubation, how do you go about extubating. So again, standardizing and making sure everyone understand the role of different drugs which are being used and what effect it has on the child, and how do you overcome that to get a successful extubation. Because a lot of times the single stage procedure, a lot of people worry is because they don't have good ICU care. And again, educating yourself and educating ICU and working as a team can make a difference, and then you can have very successful results from it. And then we talk about stents and different stents being used. There are so many different stents, but the idea of stent, again, you have a tracheostomy tube and you want something in the area where you have reconstructed so that it provides some support to your reconstruction. And so I worked with one of the manufacturers and came up with the stent. So before that, I was using a T-tube, and it just took more time. So sometimes it's the same material as the T-tube, but it is more, it's more as a block. And this is a softer part which you can cut to exact size where you need. Or this is the Rutter stent, which is again similar principles, and it has a lid on it. So the disease has not changed. The disease has been same for last 40, 50 years. What has changed is our understanding of what are the cofactors which go with it. And what has changed is our postoperative care, because we use balloon dilation a lot more. We can use adjuvant drugs, especially steroids, Ciprodex, use of stents more wisely to say some of these kids need longer placement of stent, some of these kids might need a lesser period of stent, and closer surveillance. You need to keep an eye on these kids to see what happens. This is an example of a kid who had laryngotracheal reconstruction, and you saw that the scarring had happened and everything was starting to scar down. So you need to bring them back every 2-3 weeks to initially to just make sure they're healing the right way. But this one, after 3-4 dilations, it was still starting to scar. So then you can place this stent, which has a hole in it. So you can put your telescope through it to make sure it's sitting exactly where you want. And then through the neck, you can pass a suture, which will help in holding the stent, and it comes out through the neck on the other side. Then you make a little incision, and then you can tie it over an angiocath and leave it for whatever period you decide will be good. So these are things which have changed over the years, where we have balloon dilation, which can help in some of these patients, and then you have adjuvant ways of managing things. So where do we go from here? So once we have reached a point where you know the surgery, whether you're doing a laryngotracheal reconstruction with grafts or you're doing a cricotracheal resection, they work pretty well in hands who are comfortable doing them. But things which can change is you can change some of the things because our endoscopic management has gotten so much better. Here is an example. This kid, if you look at it, has a very bad stenosis coming right up to the vocal cords. And this one, if you just let it go, you will have a very high-grade stenosis, but not just stenosis, but it will be involving the posterior glottis and the glottis, and reconstructing that will be very difficult. So what you can do now is identifying these patients ahead of time, and you can manage them endoscopically initially to say, can I break this scar band? So here I'm using a sickle knife, you can use a microdebrider, you can use a laser, a combination of these things. The idea is to break this scarring cycle and maybe inject some steroid into it, and monitor them over 2-3 sessions of balloon dilation to keep it open. So even if it goes from this bad situation to a less bad situation, it is much easier for you to reconstruct later. So some of those things can be done to improve your outcomes. Sorry. So the other aspect comes is there are situations where you don't have to do open neck procedures. So here's an example of this is a patient with posterior aortic stenosis where endoscopically you can go in, divide the posterior cricoid and place the graft endoscopically. This was popularized by Andy Inglis from Seattle. And so you don't have to always do endoscopic procedures, and we are getting better and better with not just the endoscope, but instrumentations, what can be used. And this you can see a week later, the graft is nicely in place and wide airway. And what has happened over the time is in olden days, you had to learn in a certain way, but now you have new ways of learning. You have virtual bronchoscopy, you have surgical simulators. We were talking about doing it on rabbits later on. You can do it on cadavers, you can practice on them. But the important thing, what is happening now is you have 3D printed material which you can use. And also, especially when you are in an unusual situation where something is very rare or unusual, you can create that scenario by 3D printing and then do a pseudo operation to just say what I would do in this situation. And you can do that and be prepared before you go in for surgery. So there are a lot of new ways of tackling this so that you go in prepared. So in conclusion, when complications happen, it should be a trigger for you to say, what can I learn from it? And you need to keep pushing your boundaries, because you can't stop saying that I had the last 4 cases successful, 2 cases were not so good, it's okay. We need to always be pushing to make things better. And your patient and their success should be your priority. And at the same time, your definition of success changes. And as you have seen over the years, people have changed. In the past, it was getting decannulated was success. But slowly you saw doing it in one surgery was success. Doing it quicker is success. Doing it with less doing it more economically can be a success. So the definition of success keeps changing, and we need to adapt to that. With that, I would like to finish my talk. I can take any questions, and thank you again for giving me this opportunity.
Thank you, Dr. Deepak Mehta, sir. It is an excellent talk on this subject, starting from Jackson in 1930s till date, when you don't have to touch to start with the cricoid cartilage, then proceeding to anterior and posterior grafting using the costal cartilage, then and taking care of some bacteria like Pseudomonas in advance before subjecting them to the surgery. And I thank you again for this excellent oration, Vasant Oswal oration. Any question?
Now I request, sorry, is taraf aa jaiye. Is taraf aa jaiye. Please accept oration award. I am myself, Dr. Ramlingam, and Dr. Sachin is with me, and chairpersons, Dr. Devendra Rai and Dr. Suresh Vats. Come this side. Come this side. So अलग अलग आप इसको ऐसा पकड़िए सर आप this is virtual. Can you see?
Yes, I can. Thank you.
A nice placard. Of course, we will be shipping it to US.
Thank you. Thank you very much.
Thank you.
Thank you, and we are very happy to have you here and it was good to learn. You have started your maybe practical things with Mr. Oswal in UK, his academic programs, and I'm very happy to note कि as like Mr. Oswal, you are in a big way in the academics all over the world. Thank you, and like to welcome you again to our activities in India and this part of the world. Thank you, Deepak. Thank you.
Thank you. Thank you very much.
My request, Dr. David Lau to come on. David? David, are you online?
Yes. Hello.
Yeah, hello, David. Dr. Ramlingam here.
Hi.
Hi. Please accept the oration plaque. Sir? Because the camera is there. This is the oration plaque, which we'll be shipping to Singapore. And
thank you very
you got a
much.
certificate also. We'll be shipping it to Singapore. Okay?
Thank you very much.
Thank you. You're welcome.
I would request Dr. Ramalingam to please felicitate the chairpersons. Dr. Devendra Rai.
Thank you so much. Sure.
Dr. Suresh Watt.
Thank you.
Thanks for coming. Now we break for tea, and after that the next session will start. Please join us for tea outside. By 11:30, the next session will start.
Anybody presenting in the free paper can come to the Audi too.
We'll be heading to this third session. For the third session, I would like to invite the chairperson, Dr. Amit Malik and Dr. Anish Gupta. So please, these two seats. So our first speaker will be Dr. Sachin Gandhi.
Okay.
These are the speakers and their interest.
Hello. I would like to introduce Dr. Sachin Gandhi. Welcome, sir. Dr. Sachin Gandhi is a consultant ENT surgeon and director, Department of Laryngology, Dinanath Mangeshkar Hospital and Research Center. He conducts senior clinical fellowship in laryngology accredited by Maharashtra University of Health Sciences and Royal College of Surgeons of England. It is the first overseas RCS senior clinical fellowship outside UK and Ireland. He is a founder, president, Laryngology and Voice Association, and president, Indian Association of Laser Surgery and Medicine. He is also a member of various associations like Life Member, Association of Otolaryngology of India, corresponding member, European Laryngology Society, international member, American Academy of Otolaryngology and Head and Neck Surgery, member, International Association of Phonosurgery, founder member, Chevalier Jackson Society, member, International Brachioesophageal Society, member, Association of Phonosurgeons of India, Royal College of Surgeons of England awarded the prestigious FRCS as a recognition of his outstanding work and academic contribution in the field of laryngology. He conducts senior clinical fellowship in laryngology accredited by Maharashtra University of Health Sciences and Royal College of Surgeons of England. It is the first overseas RCS senior clinical fellowship outside UK and Ireland. Sir, over to you.
Thank you. Thank you for the introduction, Chairperson. With your permission, I would start my presentation in surgical management of aerodigestive tract, and we are going to concentrate on two aspects. One is management of dysphagia, the surgical management of dysphagia, and we'll concentrate on we see those patients of organophosphorus poisoning or scarring because of radiation, maybe now has become so common in head and neck surgeries. And post radiation, these patients do have fibrosis in the oropharynx, hypopharynx, and they land up into long-term obstruction and dysphagia. We'll just go and concentrate on 2 or 3 these key elements which we can take care surgically, and then we all go to the use of balloons in management of airway obstruction. So basically the dysphagia which we as otolaryngologists see are oropharyngeal motor dysfunction, and there are various reasons for that. Achalasia of cricopharyngeal sphincter, Zinker's dialyticulum, and many other things which we see in our outpatient department. When you want to give or opt for surgical management, of course, failure of conservative management, and conservative management, as we see, is basically the swallowing therapy. And swallowing therapy, when it fails, then you have to go in for surgically correcting the disorder or the obstruction. Another thing, when patient do have aspiration, and in most of the elderly patients which may turn into life-threatening episode, you have to protect the airway from this aspiration. That could be another avenue for surgical management. A biliary dysphagia, or basically as a supplementation, because of various disorders like trismus of indefinite cause or neurological chronic elements, these patients do need or lack nutrition, and just to have this supplemental alimentation, you have to find the route to give them the nutrition, and that could be found with surgical interventions. So these are the various, causes, neurological, muscular, systemic diseases, which could affect the oropharyngeal motor dysfunction, resulting in aspiration and again surgical intervention. As a cricopharyngeal, oropharyngeal opening because of motor dysfunction, the most commonly used surgical method is open up the sphincter, and which sphincter we see is the cricopharyngeal sphincter. So cricopharyngeal myotomy in neurological cases has to be done in many of these patients to ameliorate the dysphagia or the obstruction because of motor dysfunction. Again, surgical access for enteral feeding. Cricopharyngeal myotomy, as we know, can be done externally by the transcervical approach, or there are methods to do it endoscopically. Endoscopically, you can also open up the Zenker's diverticulum. Zenker's not that commonly seen in India or the Asian countries, but we may see one or two cases in between, and then these are the specifically designed endoscopes which really would focus the shelf, which you can cut with the help of either laser or maybe scissors or some other instruments, and open up the pouch in cases of Zenker's diverticulum, or maybe open up the cricopharyngeal sphincter. For enteral feeding, either you bypass the oropharyngeal motor dysfunction with surgical gastrostomy down, or percutaneous endoscopic gastrostomy, which is the commonest procedure done in by the gastroenterologists in many of the centers, so which is we say as a PEG. If you can't pass in the endoscope, then you can locate the lesion and pass in your cannula with percutaneous radiological exposure of that particular area, and radiologically guided percutaneous insertion of the catheter you can do for the enteral feeding. So you can do it either a gastrostomy or PEG. Also you can do it with fluoroscopically or radiologically guided route. I think we are not really engaged in surgical gastrostomy or PEG. We refer them to the gastroenterologist, or surgical gastrostomy to the general surgeon. Now we go surgical, and we are going to see these images in which we are engaged as an ENT surgeon or laryngologist. Chronic aspiration. Now if there is a chronic aspiration and everything has failed, what really you have to do is closing the laryngeal inlet. Closing the laryngeal inlet would avoid aspiration and life-threatening episodes. If you want to close in the laryngeal inlet, voice or phonation is going to get affected. So there are techniques which would be either voice sacrificing, in the sense patient would not have phonation after closure of the larynx, or voice sparing techniques. This is actually when you make a raw area on the lateral surface of the peripheral surface of the epiglottis and aryepiglottic fold, and then suture it partially in the sense you just leave behind some gap posteriorly. This just for sacrifice or maybe sparing the voice of the phonation. So this could be closure of the laryngeal inlet, which would spare the phonation and it would avoid aspiration as well. Or you can suture the vocal cords, making a raw area on both the vocal cords, and then suture them up, and then prevent the aspiration, but then it would sacrifice phonation. So as per you go down, these are levels of closure of the larynx. The commonest procedure we do as an ENT surgeon is tracheostomy to prevent aspiration, because we always tell the patient, whenever you have feeding, just inflate the cuff and then you can have the feeding. But this is also not 100% safe, because there is always a passage of the food materials along the cuff of the tube, and this has been proved कि in spite of inflating the cuff, you may have clinical or maybe pathological aspiration in these patients. So it cannot be relied upon 100% to prevent aspiration. But yes, tracheostomy is the method which is we practice in many of the, most of the centers. Or you can, to avoid surgical closure, you can put all these laryngeal stents. You can just do the diversion. The main idea is to prevent the food material or aspirated material going down into the trachea. So these are the methods available. You can separate the laryngotrachea from the esophagus. These are the procedures which we can, these are irreversible. In the epiglottis or suturing the vocal cords, you can reverse them. You can just cut open the vocal cords and the epiglottis once aspiration is taken care of. So these are reversible. Irreversible procedures are partial cricoidotomy, subpericondral cricoidotomy, or narrow field laryngectomy. This narrow field laryngectomy, as we discussed yesterday also, for CA larynx, localized lesions, these things are practiced in most of the centers, or maybe in the cancer centers. So these are voice sparing, because you leave behind the functioning vocal cords. Either one, when you do a vertical laryngectomy, you spare one vocal cord. When you do a horizontal laryngectomy, you spare both the vocal cords. So these are voice sparing procedures. But remember, because of supplemental methods, I don't think these are the surgeries which are required nowadays that commonly as we find them in the literature. So there are side effects also, or negative points which have to be taken care of, like when you close the vocal cords or when you suture the epiglottis, there are lots of secretions which are going to get collected above that portion, and then patient feels very uncomfortable and really you have to open up. So I have done these procedures in 1 or 2 cases. But when you establish your swallowing clinic, you are going to get lot of references from your neurological department and in ICUs. This I have kept this tracheoesophageal fistula because this is a condition which is commonly missed in our clinical practice. When we get patients with aspiration, we doesn't think of this. We always think of some neurological cause, and we miss this tracheoesophageal fistula. A simplest test like a barium swallow also would tell you that this patient do have a laryngophysial esophageal fistula, and then you just close the laryngophysial fistula and avoid aspiration. So this is one of the case, one of the condition you have to put in differential diagnosis. And you know all these things. These stents are available, of course, when there are fistulas or aspiration fistulas because of malignancies in the esophagus. Aspiration because of unilateral vocal cord palsy. We have seen in live surgical demonstration injection laryngoplasty. I'll just show you this clip just to press upon the important points. This is done under general anesthesia. This is a high frequency jet ventilation. You inject the fat anterior to the vocal process, and then it spreads along the entire vocal cord. Then with the help of laser, you can block that opening which you have created with the needle. So this is the very useful procedure to avoid aspiration and to improve on phonation in patients who have got neurological unilateral vocal cord palsy. Now, when I started this dysphagia clinic or swallowing clinic, actually I never knew this case or this condition. I started getting references from PICU and NICU of chronic aspiration and cough on swallowing. And when we did endoscopy of these children, then I could see this cleft. This cleft is interarytenoid cleft or laryngeal cleft, what we see, and this would lead for aspiration in many of the children. I mean, this is not, let me say, this is not that uncommon. So you have to keep this when you get a reference from the pediatric department. And as you go deeper down, from arytenoid down to the cricoid, down to the thyroid cartilage, and up to the carina and down into bronchus. These are various classification is there. So stage 1, stage 2 would be just in between the arytenoids. As you go deeper, as the cleft goes deeper, stage 3 and stage 4. Type 1 and type 2 clefts, maybe type 1 would be treated conservatively, just put in the nasogastric tube, observe the child, as he grows that would be taken care of. Maybe stage 2 and stage 3 can be treated surgically. Stage 4, actually we have seen one case, stage 4 in one of the preferences, and actually we explained to the parents, it is very difficult to take care of, just leave away your baby. Stage 4, when it goes down into the bronchi, it's very difficult to treat them surgically, open surgery or endoscopic surgery. Type 2 clefts can be treated endoscopically. Type 3, endoscopy plus open surgery with a muscle pedicle graft in the interarytenoid area. As we see, endoscopically, just do a raw area on both the arytenoids and take sutures in 2 layers. So this is a clip, we'll see. Now remember, these children, this redundant mucosa, actually I will explain you in few seconds, just as a compensatory mechanism, that just to close that cleft and prevent aspiration, there is a redundant mucosa which develops there, and this mucosa would prevent aspiration, but then what is going to do is cause airway obstruction. Okay, and then these children would land up into tracheostomy. So when these children are referred for aspiration, Ryle's tube, feeding, and a tracheostomy. So what you have to start with is excise this redundant mucosa with the help of a laser or just a scissor. Make a raw area on both sides of the cleft, and then you can suture the cleft. The false cord retractor. Is completion of the surgery. You can see the tracheostomy. Actually, we just did one case who had breathlessness, but he never had a tracheostomy. Just we'll come to that case. Now this is stroboscopy after the few days, and then after 3 weeks, we examined the patient under general anesthesia, and the wound was quite healed. He was decannulated, and now he has gone back into oral feeding. One case we did. Okay, this is the redundant mucosa. Okay. This is a case of esophageal foreign body. I mean, these things you can do in your clinic. Now you can take over gastroenterologist either in the cricopharynx or upper 1/3 of the esophagus, cervical esophagus. Reflux laryngitis we have already seen. Post radiation dysphagia. This was a patient who was treated for who got dysphagia because of radiation for CA tonsil, and it was a fibrosis in the cricopharynx which you have to release with the help of KTP laser and do balloon dilatation. Don't try to exercise it in one go. Do it in steps. So again, this is a cricopharynx in which it affects the oropharynx mainly. So this is a uvula and this is a closure. This patient has only one hole for breathing and feeding. Okay. So you have to open up this with the help of KTP or a diode laser in stages. So this child was referred with Ryle's tube and tracheostomy. Again, in adults, usually organophosphorus poisoning do have supraglottic stenosis. Always remember, supraglottic stenosis. So you have to deal with them and identify the lesion in the epiglottis and ariepiglottic folds. Okay, this was a case of CA larynx, and we have seen this actually in the talk by David Love. You can now start dilating the cricopharyngeal obstruction with balloon dilatation with a TNE and balloon dilatation. I'm trying to get this manufactured in India by Merrill company in Mumbai, and I think we will start taking over this part also from the gastroenterologist in our daily ENT practice. Okay. Now balloon dilatations, very important part of treating grade 1 and grade 2 Cotton-Meyer stenosis in airway. We'll just go through the history, equipments, principles of balloon dilatation, the technique, advantages and disadvantages. Basically, it was Hebra reported balloon dilatation from laryngeal and tracheal stenosis. He used classical spherical angioplasty balloons, means circular or oblong, this one, and it had its own limitations. So Sobol and Duden actually they developed an oblong balloon which we are using now. Okay. Now basically either we have an intact framework of the larynx. In intact framework, the cartilaginous framework is intact, that is cricoid and the tracheal framework. So only problem is the intraluminal component or the fibrosis. In these cases, balloon dilatation or bougie dilatations can be tried, plus there is an option of external surgery. So remember, when there is a cartilaginous support, then you can try balloon dilatations or cricoid dilation. When there is a poor framework like fracture of the cricoid cartilage or absence of cartilage, weak or degraded framework, then you have to go in for external surgery only, like in case of laryngomalacia or tracheomalacia. Okay, there is no role of balloon dilatation. So these are the equipments. These sets are available. These are oblong shaped balloon dilators, and you have to pass in that. There are sizes as per the airway. So you start with pediatric group 5, 7, 9. These are the outer diameters of when you inflate the balloon, and you can go up to the adults 12 and 14 size. Then you inflate the balloon with the gun and then create a pressure. We'll see it in the following slides. So these are oblong shaped, these are spherical shaped. Okay, what's the principle? How the balloon acts? It's a circumferential radial pressure over the obstruction. then it also creates microfractures of the thinner part of the cricoid cartilage. You remember, it's not only the fibrous bands, but it creates the pressure on the cricoid cartilage as well and creates a small fractures there and helps to dilate. Okay, like we have seen yesterday's lecture by Thiru, mimicking cricoid split. Okay. So what are the indications? Low grade congenital subglottic stenosis. Remember, low grade. Okay. Acquired subglottic stenosis, yes, balloon dilatations would be important and helpful. Tracheal stenosis and to stabilize the airway prior to definitive treatment. There are two primary treatment for as a primary treatment for airway dilatation, and secondary treatment means stenosis developed after the patient has undergone laryngotracheal stenosis surgery. So at the site of the sutures, he can redevelop the stenosis. So that is secondary treatment. Okay, now technique is basically this is a grade 2 stenosis. You just create Mercedes-based incisions with the help of laser, open it up and then endoscopically dilate. So balloon is inflated to rated burst pressure and pressure is maintained there for 2 minutes or till saturation drops below 90% of oxygen level. So this is oblong shaped balloon. So after 2 minutes or if the saturation drops, then you can deflate and remove it. Don't repeat the dilatation in the same sitting for maybe 2 or 3 times. Otherwise, it will create a good opening, but then chances of laryngeal edema are also would increase and patient while coming out of anesthesia would develop stridor. Okay, so 1 or 2 sittings are good enough in one go. Then you can of course have topical application of mitomycin, you can infiltrate Kenacort, and you can repeat the dilatation 1, 3 and 6 weeks after creating the raw area. So this is a subglottic stenosis in a child. So creating the Mercedes base incision with the help of a CO2 laser and then balloon dilatation of the same. Now secondary subglottic stenosis, a patient who has undergone laryngotracheal tracheoplasty develops granulation or stenosis at the anastomotic site, and then you can use balloon dilatation for these patients as well. We already seen in Dinesh's lecture. You have to see these patients, especially in pediatric age group, because smallest, minimal of healing or the scarring would obstruct the airway, especially in pediatric age group. So they would need 1 or 2 dilatations after the laryngotracheoplastic surgery. It's the same, already seen. What are the advantages of balloon over bougie dilatation? Okay, so these are radial dilatations with no shearing forces. This is precise, high pressure, low compliance dilatation. These are low risk, lesser morbidity. Now, this is very important point. These balloons, when you try to inflate, they will slip either inside or they will come out through the stenotic area. Okay, so you have to just keep it and try to keep a pressure over the balloon and see to it that they would remain at the stenotic site itself. That's why from spherical they have gone into the oblong type. Okay, and a longer this one. And now Rutter has done further modification. He has put in some clips there that will hold the stenotic area and then apply the pressure. With balloon you need multiple sittings. Now there are complications like I already told you about laryngeal edema, laryngeal spasms, pneumothorax and bronchial injury. What bougies, why not to use bougies and use balloon? Because balloons would act only locally. Bougies, the end of the bougies is going down into the trachea, carina and bronchi, and they can create pneumothorax. These are known things. They can create laryngeal edema, tracheal edema also, because you are exerting the bougie is going to pass down into the trachea as well. For subglottic stenosis, you are going to insert the bougie which is going to go along. So you have to prefer the balloon which will act locally only. And bougies are blind, maybe dilatations. Okay, so there are modifications which have been done in the balloon. There is dumbbell shaped balloon also is available, so it prevents the slippage of the balloons from the stenotic segment. This I have shown yesterday also, because I was dilating the posterior glottis. I did a chordectomy there. So the glottis is a triangular shape and not circular. Okay, so when you want to exert pressure in the posterior glottis, you will not be able to fix the balloon there. It is going to go into the anterior glottis. So then what you do, either you pass a bougie there in the anterior commissure, or some suction there, or some obstruction, and then pass the balloon down. So then it will act in the posterior glottis where you need the pressure. Okay, so dilating the glottic stenosis, you have to take care to have some adjustments, so it will act wherever you want. So maybe this we have already seen. Open surgery proposed in which dilatation fails, bilateral vocal cord immobile like yesterday's case, grade 4 or pinpoint congenital stenosis. Okay. Thank you.
Thank you, sir, for excellent presentation. Any question from the audience?
Thank you. Thank you.
Thank you.
Any questions, any discussion on the with any of the faculty? You're free to come forward and do that.
We have some time, so if you have any questions for any of the faculty, you will interact with them.
So the diode laser fiber is inserted through the instrument channel of the fiber optic scope and then it is used?
See, these dilations are done under general anesthesia. So what you have to do, take a laparoscope, pass the laparoscope through your laryngoscope, you have fixed the dial scope, through that you pass a laparoscope, along with that you pass a fiber of the diode laser or a KTP laser. There are going to be the plumes. To do that, what you do, you take a suction cannula, long suction cannula, just the tubing, you make a hole in the tube, pass the diode or KTP laser fiber through that tubing into the suction cannula, and then so that suction will take care of the plumes, and then you can work with the KTP or diode laser. When you are doing OPD procedures or OPD application, like removal of some granulations or taking some cuts, then you can pass it through the instrument channel. Remember, when you are using diode or KTP laser through the instrument channel, keep the fiber at least 3 to 4 inches away from the bronchoscope, because if you keep it close to the tip, then it is going to traumatize or maybe burn the sheath of the bronchoscope. And if you remember, if you have to change the sheath, the cost is as equal to have a new fiber optic endoscope. So when you are using a fiber laser through the flexible endoscope, keep it away from the, outside the endoscope for minimum 3 to 4 inches. Yeah, you can use, but personally I have not used it. Cobbleter you can use, but again remember, if you are using a cobbleter, then again these things you have to follow, because there is going to be more of a raw area, number one, more of a slough. So 1 week and 3 weeks you have to take care. Keep these patients, because keeping in mind there is going to be slough and granulations, antibiotics for 3 weeks to take care of to avoid secondary infection, and steroids. Systemic steroids. Yeah. This is, you just make a raw area and put the gel foam there, so that is going to take care of closure of the interretinal gland. Or you can inject some material there. But I think suturing is the best thing. Yeah, suturing is the best thing. No, only thing is it will help the raw area to, even if it remains for 2 or 3 days, maybe that will create some. See, gel foam is a bio-inert, so there is no problem. Yeah, like clips. We have seen Manjuna, this Manish Munjal using clips for sutures there, just to tie a suture, and if you don't want to make any knots, because it's very difficult to pass in the knot there, so you can just take a suture and you can just apply a clip instead of creating a knot there. I use clips for fat augmentation. What I did is fat augmentation you do in the paraglottic space, so it's only medialization. You are not in a sulcus vocalis. What's the problem is loss of lamina propria. So there are people who say ki you insert fat globules in the lamina propria. Insert fat globules in the lamina propria, create a pocket there and take sutures. So just to avoid sutures, I put in some clips. That case failed. Was the fat globules, I mean, they were given out. But failure was not the reason. That girl came up and she said, ki, because you have used clips there was a failure. And are these clips safe? And I was about, I mean, I was so very much bothered about some obligation and the aggressive mood of that patient. So I found out some references and keep them along. So always remember, these clips are bio-inert. Okay, so even if these clips go down, there is nothing is going to happen. Either the patient would cough them out or would get absorbed. So always remember, when you are using all these things in the airway, you have to answer all these questions to the patient's relative and patient.
Large sutures can be tried. You don't have to get knots. I have no experience for aganoplasty.
Yeah, yes.
You don't have to make any knots.
Yeah, you can take the suture. But see, remember, it's very deep. I mean, see, almost 1 feet away from your holding hands, you have to take the suture. So I have not tried these sutures. Suture, yeah. But yeah, maybe we'll have to try them out. Good suture. Say, pass the suture. Yeah, good suture.
The titanium clips, what we use like LT100 or 200, will that get absorbed in the body? The LT100 or the titanium clips.
No, even if they don't get absorbed, there is absolutely no problem.
But if they go into the airway and if it is lodged in the
They're not going to create any infection, granulations or anything. Yeah.
Somehow they're never found when you get the X-ray done also. I don't know what happened.
Yeah, the titanium should be radio opaque, should be picked up. Like sometimes we look at some of the chest sutures or something like after a CTDS procedure, we can always see them. Maybe they are steel wires or.
Even the last workshop किया case उसमें एक titanium में लगाया. I'm sure by next week I'll not see it.
See, but see to it ki you have a CT scan just for patient answer some questions.
One thing, sir, about balloon dilatation was saying, which is not mentioned in bottles very well, is the soft versus the hard, which is the cartilaginous versus membranous. So, would you tell a little bit about that also?
Soft stenosis and hard stenosis.
Yes, sir.
I think hard stenosis balloons would also not play any role in that, apart from microfractures, if really they happen. Heart strictures have to go in for external surgery, and that's why I told you, fresh wounds, soft stenosis means they are fresh ones. As they grow older for 3 months, 6 months time, they are going to be hard fibrosis there.
So I had a case around a year and a half ago. The young girl, 25-year-old, and she had a recurrent breathing stridor without any desaturation. I walked to the OPD and it used to appear like an asthmatic case. And when we got the bronchoscopy done, some pulmonologists did, they found bands of fibrosis, thin fibrosis like wafers, at 2-3 places in her trachea. So she, I don't know, came to us and she had got intubated around a few months ago due to attack of bad bronchial asthma, which she already had initially. I'm forgetting the reason, but she had been in ICU for about 3-4 days. And she was having just wheezing, no respiratory distress. So we just went in, and it was such a pleasure to just put a balloon there and just break open those strands and come out. And that was the only time she required the balloon. Never again she required. She has been coming once in a while for cough and all, but there's no stridor. So sometimes the membranous can be
membranous, of course,
yeah. But hard, even 1 or 2 will be difficult, I think, to think of.
Balloon dilatation you did in the
No, GA. We didn't put a ET tube.
Jet ventilation.
Yeah. Easily, because there was no, we were very sure there's no respirator. We did a jet.
Anesthetic people are not much
Very, very
interested.
helpful. Very, very. In whatever I say, they'll do it.
They
Yeah,
do.
yeah, yeah. Anesthetist never says, why are you doing this? Why are
At
you-"
my place, they are not very much
He
interested
says
in
it's your
trying these
problem.
things.
Sorry, there is a little bit pause here because the specimen has to be thawed. We didn't realize they were all defrozen, so they are in the process of thawing. So it will take some time, and in the meanwhile, I'm just waiting for the results so that we can do BM Abral award presentation ceremony by ma'am. And after that, Manish, you will be presenting, demonstrating thyroplasty. Okay? No, no, laser is, there is another glitch. They are working on it. So first is thyroplasty, then injection, then tracheal resection anastomosis, then CO2 laser.
Just case of patients with tracheostomy, if you do laser and dilate.
But audience can interact with faculty here. Whatever doubts you have and everything, you can clarify here. Huh? Okay.
You have to decannulate the patient stepwise. Like what we do in the after 6 weeks, after 3 weeks, the first sitting you put it to number 5 and then close it. And ask the patient to close it as soon as possible. There are two reasons. One is decannulation after the healing of the wound, and number two, oxygenation of your wound. So the raw area, which actually I was telling, I already told this one, Manish Munjal, Yesterday we did one case of interretinoid granular stenosis. We have created a raw area. So that raw area has to heal or mucosalize. For that it is going to require oxygenation. So that patient has to be changed to number 6 tube and try to block that tube. Blocking would help oxygenation of this raw area and maybe prevention of further stenosis. So remember, after the first sitting, get down the size of the tube, ask the patients to close it as much as possible, put in a sticking there. First sitting you do, come down one size below, again try to close it. After 3 weeks when you do second sitting, put in number 5 tube and block it and call the patient after 1 month. So to help you mucosalize the wound and taking out. Don't extubate the patient in the first sitting. Always tell the patient we are going to take at least 3 months for us to decalate or remove the extubate decalate. Because you have to explain to the patient, even if we do laser and open up your stenosis, there is some point of injury we are making and is again going to heal. So we have to take care when the healing is complete and we are sure that there is not going to be refibrosis again, then only we are going to remove the successful tube.
Yes, ma'am.
ठीक ठीक हेलो ठीक है
सर थैंक यू थैंक यू
सर ऑन कर दो फॉरवर्ड में याद कर दो सर
हाँ हाँ बिल्कुल साइड में हाँ जी बिल्कुल या
ऑडियो टेस्ट करना है।
हेलो 1 2 3 चेक हेलो 1 2 3 चेक गुड वीडियो आपको सामने से आएगा कहाँ से
हाँ आ रहा है।
नहीं इसका
जूम कर लें हाँ अभी जूम हो रहा है अभी सर को रिप्रेजेंट कर रहे हैं तो जूम कर रहे हैं डायरेक्शन आपको चेंज करनी पड़ेगी सर
नहीं आप चाहो तो मैं उस साइड बैठ जाऊंगा अगर आप मेरे कंधे के ऊपर से लेना चाहें
मैं दिखा देता हूँ।
खैर वो मैं इसको हटा दूंगा तब जब आपको इसके आगे आ रहा तो ऐसे कर देंगे
हाँ थोड़ा सा आगे कर देंगे तो वो ब्लॉग बना रहे हैं तो यहाँ
नहीं अभी तो नहीं बना रहा मैं
नहीं
तो
मैं बोल रहा हूँ यहीं से आ जाएगा। इसके लिए
ठीक है या ओके आई कैन हेयर माई सेल्फ ऑल्सो वेरी गुड वेरी गुड
It is my proud privilege to announce the winners of BM Abroad session. Junior Consultant Award session. First prize goes to Dr. Arvind Karo. Dr. Arvind. Shreya, ये दे ना एक मिनट and congrats. Second prize, Dr. Jamil Manjur. On that side. Next, poster presentation, Dr. Biswajit Das. Congratulations.
ब्लॉग पर उसके अंदर लगाना है क्या उस तरह तो ये फिर दिखेगा
Second prize,
ऐसे
Dr.
होगा
Yoshita Mahajan. Next is PG free paper award session.
हाँ दोनों साइड से अगर आप ये आपको उठाने पड़ेंगे ये
ये आपके मैं इस साइड पे छोड़ दूं
थोड़ा दूर मतलब हाँ गीला ना हो जाए हाँ हाँ
Second prize to Dr. Aditya Saraf.
इधर किस साइड से लेंगे आप
In video presentation award session, first prize Dr. Shreya Srivastav.
बहुत काम करती है.
Second prize Dr. Sujita Singh. Come Sujita. Congratulations, Sujita. Wild card entry, got well. Good. Thank you, ma'am. Thank you, ma'am. It's a great honor to have you amongst us, and that's why I said कि sir का instituted prizes.
Sterilise. It can be autoclaved. Silicon तो सबसे resistant material
Thanks
है.
for
You can
remembering him
auto-
all this time. Please do remember him always in your conferences.
Always.
Yeah.
He is always there.
He always worshipped ENT and he practiced
He is
ENT.
always there in our hearts, ma'am.
Thank you so much.
Thank you. Thank you. Now we.
Because we have known sir for such a long time, but I haven't ever had the privilege of meeting ma'am. So it was really a great opportunity, at least as Smithsonian, because for Sir's Institute.
Yeah,
And following the legacy with
Great.
for me and Dr. Rangan, who are continuing with the voice training work.
We started the voice clinic at AIMS.
I know. Thank you.
The gold standard, you can say. Thyroplasty is considered.
Now we go over to thyroplasty demonstration by Dr. Manish Munjar. Manish, please go ahead.
यहीं पे करिएगा बेटर है आप
I welcome everybody in this session, and thanks for giving me this opportunity. The pain that the organizing team, Brigadier Dr. Ramalingam has undertaken to bring these specimens to you is worth mentioning here. We could have the option of doing, in fact, I also and many people suggested whatever is available locally you should get, but sir was adamant, no, that the best, only the best anatomically suited specimen should be there. Since due to ethical reasons, it's not possible to have actual human cadavers fresh cadavers for dissection in these situations, in workshop situations. We are happy to have these transported specimens of sheep for you guys from I think Mumbai, and it has costed him a lot, but I think it'll all be worth it once you practice on that. So let me first tell you about the basics of the type 1 thyroplasty. I mean, we could discuss the indications initially, and then we can go on for the actual demonstration. Unlike the other voice surgeries, it is almost like a gold standard for persistent large phonatory gap, mid and anterior more predominantly than posterior. And it is, if there is a definite lack of phonation time below 7 and breathy voice, and it is done almost at a time when all other options of doing a voice restoration have failed. For the conservative speech therapy and also things like even injection laryngoplasty and all, which should be attempted first if the person permits. But in case things are not working or it's been a long-standing situation, there is no etiology that can be reversed, like a sure shot post-thyroidectomy damage to the recurrent laryngeal nerve or a lung surgery which has caused a damage, then one can offer a type 1 thyroplasty. Ideal situations, it should be done under local anesthesia, although it can be done under general anesthesia for very, very apprehensive patients. One can use high frequency ventilation or sometimes even an awake anesthesia. However, the use of laryngeal mask and all is not ideal because it does distort the position of the arytenoids, and when you do the actual placement into the window, it may compromise and not lead you to the desired result. So best done under local anesthesia. Now let me first orient you to the specimen. We have this sheep specimen. As can be seen, I'll give you a anatomical inclination. This is supposed to be the sheep that is facing you, and if you see here, this is the lower part, this is the upper part. You have the laryngeal cartilage here with the frame. On this side, you have the strap muscles. There is a prominent hyoid bone here, so I'll call it a thyroid muscle. And I can't see any oblique line in this because the sheep has a different musculature, probably, and that is the reason. The lower cartilage, which is very impressive, is the cricoid, and you can see the stretching cricoid membrane. You can see the cricothyroid muscle here. You can see the cricothyroid muscle here going obliquely, just the way it is going in humans. And here, when you stretch it, you can see the thyroid notch. See, you can see the thyroid notch here. So we can mark it a little bit for you. If this is the lower inferior thyroid notch, not a very great pen, I think. And this is the superior one. Can you get a pen or something which works? Yeah, marker that works. Any thick one will also do. It's just not running on this. Maybe the ink is a little bit. So this is the superior thyroid notch, and which is the most important landmark, and the inferior thyroid notch. Yeah, thank you. Sketch pen will work better, I think. Yeah. I was getting the more expensive thing, but I think here the other thing will work. So this is, yeah, see, this is the superior thyroid notch, and this is the inferior thyroid notch, important for us. This is the midline. You must have a imagination of the midline. This is the thyroid ala and the superior border. This is the inferior border of the ala. I can imagine that there is a thyroid tubercle kind of a thing, but I am not very clear whether this can be called a thyroid tubercle. But this is largely the inferior border, and I have cleared the muscle on this side, but here you can still see the muscle over the insertion of the cricothyroid muscle on the back external branch, and also the thyroid muscle. So this is the side of the larynx that you can see, the laryngeal cartilage, pretty quadrilateral in shape. I would not complain. The human cartilage is a little bit more broad, and the posterior wall is not that oblique in humans. Here it is a little bit, so we'll take that into consideration while we are doing the demonstration. Here, when you look and have a kind of an endoscopic view, you will see that these are the glossopharyngeal folds which we have retracted now. These are the pharyngoepiglottic fold. You can see the vallicula. And then we lift the thing, there's the epiglottis coming into position. See, a bigger epiglottis. That's how probably the sheep bleats a lot and makes its noise. And you can see the posterior commissure. You can see the large cricoarytenoid joints. And you can see their movement is going on the cricothyroid. And this is the cricoid cartilage. It's pretty long. Even in humans, it's not short. And if you can see through this, you can see both the vocal cords. Now, what is good in this specimen, unlike even humans, is that it looks to be soft, and therefore we can go ahead with this thing. If there are any questions so far regarding the structure, orientation, please ask and we will demonstrate it again. Okay? So if all's well, then I'll go forward. Now, what I did in this side, and I'll show you while cleaning the larynx, this was a muscle on it. You would be required to clean the muscle off the larynx, laryngeal cartilage, for a full view. So I used a little bit of a cut till the perichondrium from the midline, and that's how the incision should also be. You give the horizontal incision in the neck, then the person does a dissection which is deep to the between the deep fascia and the muscle, and then you have to lift the skin, and somebody has to retract the skin edges to such an extent that you get a good oblique diamond view of the entire thing, where you can see the cricoid bone later lower down, and you can see at least the above the superior ala area, and up till the cricoid, the hyoid bone, you should be able to palpate. Once you have done that, and this has to be done on one side of the neck where you are doing the surgery. For example, this is the right side. After the exposure, you will see you must palpate the muscle, the notch of the thyroid. You must palpate the notch of the superior thyroid notch, the inferior thyroid notch, and once you are sure, you can draw a line. Even in a live surgery, you must do all these landmarks by drawing. You can even do surface marking on the skin if the skin is thin enough. Once you have done that, and the muscle comes after the fascia, carefully retract and cut the fascia away, because sometimes it does carry branches of the anterior jugular vein in this, and even in the center you can have a superior based anterior jugular communicating branch. So it can lead to very disturbing bleeding at this time. Do not do a very wild fast cutting with a cautery. First identify the blood vessels, and then once you have done that, for a type 1 thyroplasty, give a median raphe cut. So once that is done, retract the muscle on the sides using a elevator, and here I've elevated it to the posterior cartilage edge. But in reality, there is an oblique line that you can see by where the oblique muscle inserts the thyroid muscles, and in that area you should be able to just elevate, and rest you can just palpate and make the idea about the where you want to make the window. Now, once the thyroid cartilage has been retracted and given, and you know where the superior and inferior, the most important landmark is your superior inferior thyroid notch. So if this is the notch and this is the inferior one, you measure it, and here you can see, if you see it roughly, you need vernier calipers, which are the best three-dimensional measuring instrument. But if I do it with this, then roughly this is 4 centimeters here. You see, about 4 centimeters it's coming, and so at 4 centimeters, wherever the midline is, at 2, I make a mark with a pen again. So this is 4 superior, and this is a little bit more, or maybe 3 point. Okay, I'll measure it from here, so 3.5. So we'll go in and mark it at roughly around 2, which is the upper center mark for our measurement. Okay, this becomes our midline between the upper and the lower. So it was roughly 3.5, so I made it around 1.75. And then you measure the other part, and that is you draw a parallel you mark the inferior edge now from the thyroid notch to the back of the backmost part of the thyroid inferior cartilage, and from the notch and here you take a straight line and you see this line. So in this situation you will have to mark this inferior line like this, if at all. Our window will have to be parallel to this line, and it'll jump the thyroid tubercle. The thyroid tubercle should not come as a part here, so it should go between this line and the border. So this is our inferior border in a way, okay, and it is bypassing the thyroid tubercle, but it'll end up in the end only. So it's like that. Now we have this exactly parallel. We draw a line in the mid going back to the muscle. This is a cartilage which has a different dimension than the humans, so it'll go like this till the back, and then once you have made this line, the second line you have to make a window. Now how is a window made? We have a situation like larynx where the first anterior border should be around 5 millimeters behind at least the anterior notch. So take a 5 or a 6 in an adult. In a large larynx you can take up to 6 to 8, but in a small, this thing you must take 5. So here I am taking around 6 because it's a elongated large larynx, and since this thing is a little bit dicey for working, so I'll just puncture it first and then mark the place of the probable window. And then again, what should be the size of the window? So if it is to be drawn a parallel, then there should be a gap of at least 3 to 5 millimeters above this lower edge, otherwise you will tend to cut it. So first you mark the midline like this. The mid-caudal line we have marked, and I'll try to run the sketch pen over it so that it takes the mark. Yeah, we got so this is the line which we have made it, and then we make a window, as I said, 0.5 millimeter below. This is exactly around 0.5 millimeter, and we have to have it at least 5. Now here the distance will be a little bit bigger because this is a large window. So here I am making the border line. If that's was the thing, then somewhere here this would be a lower part, but the distance behind 5 millimeter would be like this. If this is around 5, I make the window here, the anterior border. This should measure around 5 millimeter, and this one, then the whole length of the window could be between 6 and 8. So here I will make it for 8 millimeter. And I also have an idea about how much elastic block I have to do the surgery, so I'll keep it roughly around 5 only. So this becomes a window on this side, okay? So this is the parallel to the inferior border. Technically it should be around 5 millimeter. I'm taking a little bit more in the sheep because I know the vocal cord will be situated a little bit higher up in this case. So this is the side of our window now that you can see. If there are any questions about this, you can ask me, otherwise I'll go for the window making. Now once you have done this thing, one need to start doing a shallow cut. You have to go with a very sharp blade and through the periosteum. Earlier we used to raise the external periosteum. Nowadays we don't do it anymore because it's not required and it's not good for the health of the cartilage. It can cause pericarditis and things. So just give a cut on this side and raise it enough, but not up cutting the inner part or inner pericardium. One needs to be very careful. This is a very soft cartilage, so when you are doing the dissection, be careful. Even I have to be. And this is the window that you would give. You need an assistant actually here to help you stabilize this thing, but everybody will be doing their own. So this is how you do it. Once the cut is given, then you should use a very fine Cottel's knife and try to raise this cartilage from here. First thing that you can note down is whether your cartilage itself is getting pushed. If you remember the early thyroplasties, they used to do by just making this thing and then pushing the cartilage itself inside. See, you can push the cartilage itself inside. But nowadays, no. So once you have given the cut, you undermine it and then you raise the cartilage. It doesn't come out usually so well in thyroplasties. They are usually attached a little bit more. This is really fine, and I hope you will also enjoy it, all of you. So you raise this thing and bring out this cartilage that I have given a cut upon. So very anterior placed window will cause problem by not leading to enough movement, and very posterior based window will be a total disaster. If you have to err, you must err on the side of the making the incision a little bit anteriorly, so that you can always revise it and bring a thing forward, but don't go too posteriorly initially. And here also we just one more sliver I must, yeah. I'm just making it a little bit more fine. So that is our window made. As you can see, if you can see the dimensions of the window, they are roughly 0.5, 0.2 around by around 1 centimeter, as you can see. Now, once the window is made, I will come down to the making of the block. As you can see, this is a silastic block that you can make out, and for the simple logic, we are thinking about implant that is a type of a triangular implant that can push the posterior part of the cord more than the interior part, and it should be also not pushing on the arytenoid, because then it will be a static structure and not move. So somewhere the mid cord should get the maximum bulge of the implant, and of course the implant needs to get stuck inside the cartilages. So in a human, usually a 2 millimeter cut is usually left for the this thing, but here it is much lesser, but doesn't matter, we'll still use the thing like that. And at the same time, we would like to tell you the dimensions. For a human, we use usually leave a margin of around 1 to 2 millimeters. 1 to 2 millimeter cuts we make slits here. See that? And this is for the window, of course. And the other cut we make a little bit here on the posterior side. So these are 2 millimeter cuts. These are 2 millimeter cuts. And then we can do the measurement on the lower side. Usually the difference between the both sides should be around 8 millimeter, but I'll even keep it a little bit more. This is 8, yeah, this is roughly 8. So I'll use the whole thing actually. So we will not cut it any more from here. We'll use the whole thing from here and keep the mark, one mark here, and then slide it all up till this part, where of course now you need it to be slid inside. So there the implant can be cut in a slide. The type B has a gentle curve to it when you take it above, and it goes in a direction. Hey, okay, use a 11 number. 11 hai yahan pe ek pada tha. Yes, that's a very good idea, because I was not aware that there is a 11 number blade. Actually, you will give a better cut on this. So once you do that, it's a simple design. Keep it simple, nothing complicated about it. यहाँ पे, यहाँ, and you bring this up, and here also I've kept 2 millimeter of space for the design to slit in. So it is almost a vertical stab incision that you will. I'm doing a sideways so that you can see. And some people make it a little bit horizontal for the thing to fit in well, like this. So once this implant has formed like a boat, it's called a boat implant. Can everybody see this? Now, although this is a very easy slit that I hope to put in, but at the same time, I know in a normal human being, this is always a challenge. So we give release cuts on the implant up to around 1 millimeter till the depth. You can give release cuts like 1, 2, and even 3. If you want here, 2 are enough, so that you can actually manipulate the implant by putting. So how is the implant put? You take the implant and first see whether it's fitting. Put the anterior check first, but best is while actual insertion of the implant, you must put the posterior part in well, like this one. For light, this one works or no? I'm a little bit loss of light. Yeah. And then just press it in, and here you find the implant fitting, right? And then because you have manipulated it well, you must see it fitting in well. Can you see the whole implant fitting in? Yeah, thank you, sir. Can you see the whole thing? But yeah, it should not also too much. There's too much. The internal perichondrium is very weak, so it's slightly sunken. Now I like to see whether we have a good movement. ये अंदर का दिख जाएगा, हाँ? दिख रहा है? So I am trying to move it and check. What? Okay, if I press this, कोई ये आपको सर इससे push करेंगे? I'll see first it's moving or not. So, नहीं. Yeah, you need to stabilize this first. Huh? 1 second. Yeah. ये gloves पड़ा है. So somebody needs to hold it like that so I can demonstrate. ना ये दिख रहा है ऐसे. ये अंदर से इसका green दिख रहा है. ये ऐसे हाँ. Tilted, sir. Yeah. So when I'm, if you can see this thing now, a little bit open, I must see the implant. So you can actually see the movement. I'm pressing on the implant here, and you can see the movement, cord movement, and it's exactly in the false area. Sorry, true area. Here it is. थोड़ा सा सर ऐसे. No. Like this. Yeah. So I can move the thing very well. So this is going to be easy for you guys also because it's very soft. So thank you. It's almost sinking like butter inside.
Okay, thank you.
And you would like to show them the arytenoid AA? Time नहीं है. Okay. Yeah, photo. Midline is 0.5. Actually, this is much more because this is a huge larynx. But it's around, in humans, it should be 0.5 to 0.6 centimeters. So even this distance here is almost 1 because I could make out, ये ना ये मिला रहे हैं तो ये अंदर जा रहा है, देख रहे हो? लेकिन अगर हम इसको कन्वेंशनली देखें तो यहाँ पे इसका लोअर एज होना चाहिए, ठीक है? तो वील मेक अ विंडो स्लाइटली हायर, दैट्स हाउ वील डू इट। या आ जाए, शुड आई पोज? नो नो नो। यू नो, एक भी फोटोग्राफ वर्कशॉप का नहीं हुआ।
मेरा सब फोटोग्राफ कर लिया है मैंने।
मेरे को ध्यान में नहीं आया। हाँ? Yeah. So see, I was actually made a idea myself. So no, I'd seen the vocal cord and the ventricle. Wow, thank you, sir.
तेरा ही है ना?
हाँ, बिल्कुल।
कोबरा तो तेरा ही है।
So I had to make it a little bit higher.
इतना अच्छा और कहाँ हो सकता है यार?
Pensive, look intellectual, which I am not. Yeah. ठीक है। So what is happening is you will see the internal perichondrium is so slimy. Plant is just going in. It's not rolling. Sorry? वही मैं सोच रहा हूँ निकालने का, कैसे निकालूं थोड़ा निकल रहा। Yeah. See, this taking the internal perichondrium with it. है ही नहीं।
उसका शेप देखना।
वो भी आप सब बनाएंगे, all of you.
This one. The crisscross side is outside.
Yeah, towards us. Yeah, because you have to fold it like this and put it.
Next कौन सा है?
हाँ, ये मैम को लगा दो। ये मैम को लगा दो।
इसको निकाल देगा।
On the other side also you can make it. It's very well preserved. आने का दिल कर रहा है, मैं बता रहा हूँ।
Cricoid is like.
Okay, you have lunch? नहीं वो lunch ready. Lunch ready है. What time? 4:30. 5. Thanks, Roger.
Bye. Okay, so I'll do a quick demonstration of injection laryngoplasty, and ऐसे अभी ठीक है? So I'm just getting a hang of the anatomy because, okay, so as you can see, this is the epiglottis, the arytenoids, and then you can see the cords inside. So this is the view which you get from the fiber optic laryngoscope, and here we are not going to be doing anything from the inside. Whatever we are going to do is in the neck of the patient with a view from the inside through the flexible laryngoscope. So whenever we are doing an injection laryngoplasty, I think the most important thing is anesthesia. So the first and the most important thing before starting injection laryngoplasty is anesthesia. So the first thing which you do is you palpate all your landmarks on the surface of the neck. That is the the thyroid cartilage, the cricoid cartilage, the cricothyroid membrane, and here we have the thyroid membrane. So like I demonstrated yesterday, I think the percutaneous, there are 3 ways of doing injection laryngoplasty. You can either do a cricothyroid membrane puncture, a transthyroid injection, or a thyroid membrane puncture. The easiest is this one. And the next would be the thyroid. The most difficult is through the thyroid cartilage, because you have to pierce the cartilage, and in case of calcification, it will be really, really difficult. So the easiest would be a cricothyroid membrane puncture. We give local over the skin, 2% xylocaine. And the first thing which we do is to give an intratracheal block in these patients. So if the patient is sitting like this, the idea is to puncture the cricothyroid membrane and instill approximately 1 ml of the xylocaine. So you puncture the cricothyroid membrane in the midline and aspirate a little bit to see whether you are in the trachea, and just inject 1 ml of the xylocaine. The patient will cough, and I think that is the best way of anesthesia. After this, you can instill a lot of 4%. When you put in the scope and you're visualizing the larynx, keep pushing in 1 ml of xylocaine through the scope, so that you have a very, very well anesthetized larynx. If the anesthesia is good, the procedure can not take more than 5 to 7 minutes. So you need a team of 2 people, 1 person holding the scope and the other person injecting. So you are visualizing from here and injecting from here. So imagine if this patient had a left vocal cord palsy. So we have to medialize the left cord. What you would do is that if this is the midline, palpate your cricothyroid membrane. We generally use a 22 gauge lumbar puncture needle with a 1 ml preloaded syringe with Restylane. So if this is the midline, you will start a few millimeters lateral to the midline. You pierce the cricothyroid membrane, and once you're in the trachea, you will get a feel. You will give a feel you'll get, and that's when you can see. Shreya, can you hold the specimen for me, please? Thank you. एक भी को light दे देना अंदर. Just you have to pull this like this, because otherwise nobody can see the cords. Okay, इधर इस तरफ. So we have to inject. If we have to inject on the left, yeah, thanks. The left cord, don't pull it too much. Just slightly. Left cord. Just let me put your finger out. I need to see this. Okay, now hold it. Shreya, can you give some light inside? So once you are in the trachea, idhar, andar dikh raha hai? Can you see inside? हाँ, अंदर लाइट दे दे श्रेया. दिख रहा है ना? इधर से देखो. हाँ. So once you see the needle, now you have to decide where you want to inject. So usually the injection is given either in the mid or the posterior third. We try not to give the injection in the anterior 1/3, because if you inject too much there, the patient will get a strained voice, and you don't want that. So while vocalizing, you will get a fair idea where the bowing is the maximum. And once you see the needle, you have to manipulate it, puncture the vocal cord, and then, because my angle is very different, so puncture the vocal cord, go deep into the paraglottic space. You should never inject in the superficial layer of the vocal cord. Inject a few ml here, and you will be able to see a little bit of, medialization happening. Actually, the bulge is happening here, if you are able to appreciate it. And then you should not inject the entire material at one point. I take it out and then reinsert it at a different place where you think medialization is required again, and then inject more. Usually 1 ml is sufficient, but there are times when the medialization is not adequate with 1 ml preloaded syringe, then you have to open another one and decide how much more you need to give. So if your angulation is correct, if you go from the midline, you will never be able to angulate and go. So suppose if I go from the midline, it will be very difficult for me to inject on the cord. You will enter the superficial layer of this cord and not be able to inject in the deep paraglottic space. So it is always advisable to go a little on the other side rather than from the midline. So it's just a matter of practice, and I would say that the person who's assisting you or working with you and showing you through the scope is also should be very skilled enough to show you the right place. One more thing which I would like to show is that if you're injecting a thyroid membrane through the thyroid membrane, what we generally do is we bend the needle at 2 points. So we take a longer needle, this is a shorter one, and this one is long. So this is a longer needle, and we will bend it at 1 centimeter from the tip once, and again after 1 centimeter once again. So you have a doubly bent needle, and you can use this to pierce the thyroid membrane and inject. Okay. Okay, just hold it. So this is the thyroid cartilage, this is the hyoid, and you can insert your needle at the deepest part of the thyroid notch. You can see the part where the needle is coming inside. You will be able to see this through the fiber optic laryngoscope. And once you're inside and the needle is completely inside, because it's doubly bent, it is pointing downwards. You can either manipulate it to the right side or the left side. You can inject steroid, you can do injection laryngoplasty. Can you see the needle?
Yes.
Yeah. So you can bend it to the right, to the left or the right, and inject steroids or hyaluronic acid, do a medialization, and this is another good way to do this procedure. Okay, I think now if there are any questions, I mean I can answer them, and then Dr. Ramalingam will be doing a tracheal reconstruction now. ये सब यहाँ से हटा दो. मैं लेती हूँ. हाँ ये निकाल, ये भी निकाल दे. ये सर को दे दे. मैम आपके पॉकेट से.
Hello. Hello, ma'am. This is Dr. Muntasir from Bangladesh. I would like to thank you for inviting us and giving us the chance to be a part of this arrangement. So I am having some of the queries, if you could clear them up. Ma'am, can you hear me? Hello, ma'am.
7 number glass.
Yeah. So I would like to ask you some question, if that's all right. Okay, ma'am. So I have taken some notes. So I have multiple questions, actually. So you said to anesthetize the interior of the larynx, you're going to have puncture the cricothyroid membrane and then give some local anesthetic, and after that you can use the scope, and through the side channel you can give some other locals as well. So I was thinking that how much can you give in the first puncture?
That is very important, because that has happened to one of our patients. Our resident kept on injecting and she had toxicity. So now we make sure that we don't give more than 10 ml
10 ml through the cricothyroid puncture?
No, no, in totality.
In totality, okay.
Yeah.
Okay, so how much should you think it would be enough for a cricothyroid puncture? How much?
1 ml.
1
Just
ml.
1 ml. You aspirate when you get air. It tells you that you're in the trachea.
Yeah.
Just give 1 ml. Patient will cough, so it spreads into the entire larynx.
Okay. Now,
Patient starts coughing.
It spreads to the subglottic larynx, right?
No. When the patient is coughing,
so
what happens when you cough? All your secretions come out, right?
Right.
So when he's coughing, all the injected xylocaine, it comes up into his glottis and his supraglottis.
Okay.
So that helps anesthetize the whole larynx.
Okay, ma'am. Ma'am, is it possible that can the anesthesia be done with only this giving local through the side channel of a
You can, but I feel the requirement of xylocaine through the side channel, the amount you need to put becomes lesser, much lesser if you give a intratracheal block.
Okay, ma'am.
So most of the times we don't, because when you put in the scope, when it touches certain structures, you come to know whether the patient is having some reflex or not. So half the anesthesia is already done. You just need to inject 1 or 2, maximum 3 ml after that.
Okay, ma'am. So what's the length and the gauge of the needle that you're using for?
We use a 20, this was a normal needle.
Okay.
We use a 22 gauge lumbar puncture needle.
Oh, okay. Both for the injection of the hyaluronic acid and both for the spread of the local. I mean,
No. Local, you can use a normal needle.
Okay.
You can use a normal needle for
Yes.
with a 1 ml or 2 ml syringe.
Okay.
You can just do a puncture, and because you need only this much of space to go into the trachea.
Okay.
So you need a smaller needle. For the injection,
Yes.
you need a 22 gauge lumbar puncture needle.
Okay, ma'am. Then I am having to make multiple punctures, one for anesthesia and one for the actual injection.
Yes.
I mean, is it omittable? I mean, if you could use one needle and use it for both the.
But it'll take some time for the patient, for the larynx to get anesthetized also, right?
Okay,
You will
so-
give it some time.
Okay, how much time would you give?
So we give the intratracheal block.
Yes.
And in another 1 or 2 minutes, we start putting in the scope, and then we start injecting the xylocaine.
Okay.
And once we feel, while putting only, you will come to know whether it's anesthetized or not. After putting 2-3 ml, once it's anesthetized, then we start our injection.
Okay.
So
Okay,
it's a matter of like 5-7 minutes.
Okay, ma'am. The last question here. So, if you're using a spinal needle, so the materials that you would be able to inject through the spinal needle is limited. So, only hyaluronic acid or something else you can also inject. Like
So availability of material is restricted. We used to use agarose oil.
yes.
We have done a lot of cases with that, but that is not available now in India. The only thing which is available, last question. The only thing which is available is hyaluronic acid. There was a time during COVID where nothing was available. So we couldn't do anything. Now the only thing which is available is hyaluronic acid.
So you can't use fat. That is not possible.
Fat you cannot inject through the neck.
Okay.
You have to take the patient under GA and then inject fat.
Okay, ma'am. Thank you for your.
You're welcome. Now we'll have a tracheal reconstruction demonstration by Dr. Ramalingam. Any questions? I think we can take it up a little later so that your hands-on session doesn't get delayed. Okay?
Hello, can you hear me? Good afternoon, ladies and gentlemen. This is sheep trachea, and first I want to cut 2 rings to show how it can be, rather one ring. This is very big ring actually. I want to show how, it can be 2 rings, 3 rings, but in this case the posteriorly esophagus is not there. So I have to take care, otherwise it will be through and through. Tooth process. Stabilize kar. See, this is the defect. Now, the posterior wall, I have to cut little bit so that you can do the same thing you are going to do again. I am cutting it and I'll show you how it is, how this can be sutured. This is for demonstration purpose only. No need to cut like that because there is posteriorly in patients you will have esophagus, so there is no problem. Now first what I do is I have to take a suture, first posterior ring, go internally, come out, externally come out, and then take the suture like this. You all will be given this suture material, and here also again this is a very thin larynx, a thin trachea, sorry. So I am taking this, and what we do is सीजर्स नहीं है और ये ब्लेड से काट देंगे. Now we have to take 2-3 sutures the way I have shown in the presentation today morning. This is one suture. You have to take another 2 sutures, and here I have to do because of paucity of the mosquito like this. Because the knot posteriorly it should be inwards. So one second. So again I have to take posteriorly. Posteriorly you take suture and go like this. This is the posterior one. You will get see the way I have shown you in the presentation today morning. If you do, you will not have any problem. So posterior wall is sutured. Now we go. You have to go. This is the time. This is the time. This is the lower one. Here already your tracheostomy tube is there, and you have to put another tube through nose. It comes out from here. Like this, it has to come. Can you see?
Yes, sir.
Now this one go inside like this, and here you have to take the sutures over it, over the tube. Like this. First you take lateral. Anterior ones are supposed to be taken at the end. First you take lateral. All the sutures should be submucosal. In this case, since it is a sheep larynx, I don't have much tissue. They are very thin tissue. So on this side we have taken one lateral suture, so I have to take on the other side here. Okay. It is like sewing any tube. But when you do actually on the patients, then you will realize how tough it is. Now the antemost ones, we have come to antemost portion. Good. So in a living object, usually we put, I put rather, 3 to 4 sutures posteriorly, 1 each laterally, and anteriorly 3. So with that, my anastomosis gets completed. And after that, what I do, I ask the patient, anesthetist to do Valsalva, and I put water over it to see whether the trachea is properly sealed. Okay, can you see that?
Yes, sir.
Is now completely done? Okay?
Yes, sir.
So this is how you are going to practice during the afternoon session, and you follow the YouTube videos and all, then you will know how to do on a live patient. Any questions we'll do during hands-on training or during lunch hour, because we are already getting late. Thank you so much.
Sir, one question.
Yeah.
Which suture material do you prefer in this?
Yeah, it's a good question. Earlier we used to do Prolene 2O, but I've given up since last 15 years, because Prolene, if it is protruding in the lumen, it causes granulomas. So I have given up. Now I am using Vicryl. Vicryl usually lasts for 3 months or so. So within that time, the tracheal anastomosis heals up very well. About 2 months back, I had done one with PDS. PDS is also another very good substance.
So with Vicryl, do you have to place more knots in it?
No, Vicryl you don't have to put more knots, because Vicryl only 3 knots are good enough. It is a braided one. If you are using Prolene, you have to use in 2, means at least 3, 4 or 5 knots you have to put.
Okay, sir.
PDS again, you have to put 4 or 5 knots, because PDS is also almost a monofilament.
The Vicryl is again like 30 or 20.
No, Vicryl 30 or 20, it is a braided, so it doesn't slip. The knots don't slip. Whereas PDS is again monofilament type, so the knot may slip. That's why you have to put 2 extra sutures, extra knots. Okay?
Thank you, sir. Sir, one more question.
Thank you very much. Now we go to CO2 laser demonstration by Dr. Sachin Gandhi.
Sir, excuse me, sir.
Yes?
Thank you, sir, for your nice demonstration. May I ask you one question, sir?
Yeah, please.
At first you have started some continuous suturing, then interrupted. Why, sir?
Not continuous sutures. These are interrupted sutures. These are not continuous sutures. Interrupted sutures, posteriorly I put at least 2 3, laterally 1 each, anteriorly 3. This is a demonstration, so to cut short the time, I put posteriorly 2, laterally 1 each, and anteriorly 2.
So, sir, at first we should start posteriorly.
Yeah, you have to start posteriorly. Otherwise, if you suture the anterior one, how will you go to posterior one?
Yes, sir. Thank you, sir.
Okay, thank you. কোথায় ছিল রে? কোথায় ছিল?
तो कैमरा इधर से रखूं या इधर से?
इधर आप एक्चुअली इस पे रखे, उस पे रखना पड़ेगा बिकॉज दे विल लाइक टू सी दैट या।
ठीक है सर। कनेक्शन देना।
लेकिन बोर्ड कहाँ लगेगा? ऑडियो हो गया फिक्स?
मैं एक बार देख लूं कि वहाँ
ऑडियो Hello? Hello, can you hear me? Anybody in the hall?
Yes, sir.
Yeah.
We can hear
Anybody
you.
in the hall?
Sir, yes, we can hear you.
Yeah. Now we have to try to understand the principles of chordectomy and arytmectomy. So this is the vocal cord on the left side. This is the vocal cord on the right side. This is a big arytenoid of the ship larynx. Okay. Now what we are going to do is do posterior chordectomy. Try to take the incision here on the arytenoid and remove part of the arytenoid. Okay. Ready. Okay, so let's start with the laser beam. Easy. अभी अभी ठीक है नहीं ठीक ठीक है That's okay. ठीक है वेटेज डेप्थ थोड़ा बढ़ाना पड़ेगा okay. Where is the forceps? Forceps. Can you put it on a continuous or pulse mode because this is single mode पे है
Time of point two, sir. -2. That is 3.
Yeah. So I'm on the arytenoid now. नहीं वो एक्चुअली होल्ड करने को कुछ नहीं है. So you can rotate the beam with a joystick. So I'm removing part of the arytenoid. Maybe this would be the incision. You can rotate the beam. Can you see I'm
Yes, sir.
removing part of the arytenoid. थोड़ा बीम का लेंथ कम कर 1.5 करो नहीं तो 1 किया तो भी चलेगा. You can reduce the length of the blade. I made it a 1 millimeters. You can go up to 4 millimeters also. Okay. Now it is 1. Okay. Now you can use continuous mode also. Continuous mode is going to create lot of heat and lot of thermal damage. But when you are not concerned about the functional recovery, then you can use continuous mode. Like in arytmectomy, we are interested in excising the airway, not really interested in the phonatory pattern. So you can use continuous mode here. Now this char tissue you have to always have to clean it with, let me hold this, clean it with neuropathy, because when you fire on the char tissue, you are going to create a lot of raw surface. Okay, we'll just try to get. Yeah, एक मेरे को वो turn foot. So this is basically this is part of cartilage and you can see soft focal cord. Okay, just try to hold it off with the forceps. Excellent. Secure. Steady.
This is chordotomy. Yeah. So now this we have completed chordectomy. Can you see now?
So,
Okay. ठीक है. Sorry.
They are different sizes. They're already carved out. Yeah, it's blue in color. I don't know what company makes it. Yes, yes, yeah. तो उनको फिर इतना ज़्यादा नहीं काटना पीटना पड़ता है, थोड़ा सा ट्रिम करना. हाँ हाँ.
एक बार आपको बात स्पीकर से कुछ अरे
Recording stopped.